Start to. Hey guys, this is Dr. Aman Setiya, your medicine faculty. So today we'll discuss some of the expected questions and topics. So this is a presentation which I made from past analysis of 3-year papers. So let us discuss what we can expect. So you can ask your doubt in the comment box. So meanwhile, I'll be answering your doubt as well. So let's get start with the first question. You will have 30 seconds. In exam you may have 1 minute, but here you will have 30 seconds to think and answer. So first question, let's start with this. Try to answer. A 69-year-old. So let me highlight the things. Now understand this. Time is running, so you may not get enough time to read the question again. So try to make your diagnosis in one shot. So let us see. 69-year-old Indian male complaints of painless lymphadenopathy and intermittent fever, drenching night sweat, loss of appetite. What is the subtype of HD? HD means Hodgkin disease. So what is the subtype of Hodgkin disease you can suspect in this patient? So try to comment your diagnosis, what you think. So just when we see this question, can anyone comment on this? So you can see 69 is a good age. So like an elderly Indian male. So if you see the question, complaint of painless lymphadenopathy. So when I see the word painless lymphadenopathy, so it means it could be a lymphoma or leukemia. So they are mentioning you here Hodgkin disease, so that you already know. Now see intermittent fever. This like intermittent fever which persists for a few days, then automatically resolve, then again this will reappear. This type of pattern of fever, what we call this? We call this Pell-Epstein fever. So this is itself a question like Pell-Epstein fever, where we see Pell-Epstein fever we see in Hodgkin lymphoma. Okay, then seeing forward, you can see patient is having drenching night sweat, loss of appetite. Drenching night sweat, loss of appetite. These are the symptoms. Decreased appetite, anorexia, night sweat. These are the symptoms we call in lymphoma. We call them as B symptoms. So a simple question, and they are asking you like, what is most common type of Hodgkin lymphoma in India? So most common type of Hodgkin lymphoma in India, the answer is mixed cellularity. So I know you guys are having trouble answering this question. So let me make this very simple. So this Hodgkin disease or Hodgkin lymphoma, I can classify this into two categories. So first is called atypical type, typical or classical type, and second is atypical type or unclassical type. Now understand this. If you see this typical type, we have 4 subcategories in this, and in atypical we have only one. So to remember this, the easy way to remember this is, I will tell you like simple language. There are 4 type of people in society. Listen to me very carefully, and I can guarantee you, you will never forget Hodgkin lymphoma in your entire life. So we have 4 type of people in society. So we have some rich people, we have some poor people, right? We have middle class, and we have a type of people which we call them show off, like those people with less money, but they have expensive hobbies or expensive things they want to buy. Clear? So rich, poor, middle, show off. Doctors are like bloody show off. They are earning less in India, but they want to show they are doctors, they are rich. So that is, understand this. Atypical type is something which you have to remember this. This is called Ambani. Ambani means Ambani is Ambani, or you can say Adani Ambani. He is very rich. So now convert the money into lymphocytes. So remember, I told you about money. Now I am converting this into lymphocytes. So rich means lymphocyte rich. Poor means lymphocyte poor. Middle class means mixed class. So we call this mixed cellularity. And show off means we call this nodular sclerosis. This is show off. On the other hand, I can say Ambani. This Ambani is called as lymphocyte predominant. Lymphocyte predominant. Clear? So these are the 5 types of Hodgkin lymphoma which you have to remember. So let me label this 1, this is 2, this is 3, this one is 4, and this is the 5th type, that is lymphocyte predominant. Now you have to remember this, like all these are typical and atypical types. So understand this, like whenever we travel in flight, you can see some rich people, you meet some poor people, you meet some middle class, you may meet some show off. So remember, the one person you will not meet is Ambani. So Ambani is something which you will not meet. So this Ambani is considered different from others. So this type is called histologically distinct. Histologically distinct from others. Clear? So let us write few questions and remember this concept in your exam. Then you will never forget this. If I ask you most common type overall. So overall most common type in the world, all people are show off. So show off means that is called nodular sclerosis. If I ask you most common type in India, most common type in India, so Indian people, like they want to save a lot of money. So Indian people are they believe in saving. So we have middle class. Middle class means mixed cellularity. Mixed cellularity. Okay, then I can say, suppose these are the 5 categories of people and the treatment is available only in US or in Europe. So who can afford to go to US? So best prognosis. Can a poor person go to US? Answer is no. Can Ambani go? Yes, Ambani can buy that damn hospital. So best prognosis is lymphocyte predominant. Best prognosis lymphocyte predominant. And if I ask you worst prognosis, any guesses? Any guesses? Try to answer. Try to answer, guys. Jack Sparrow, Gaurav, any guesses? Worst prognosis, what do you think? Who cannot go to US? Right? This is lymphocyte poor. Lymphocyte poor is also called as depleted. Depleted. So these are the MCQs of Hodgkin lymphoma that you have to remember for your exam purpose. Simple. Okay, now understand this. All these Hodgkin lymphomas, irrespective of the type, they will have a classical pattern of cell. These cells will have all eye shape. We call them Reed-Sternberg cells. Reed-Sternberg cells. So these are called Reed-Sternberg cells. In some places you will see these Reed-Sternberg cells can be modified. So this modified Reed-Sternberg cells, so I can say we have different types of Reed-Sternberg cells. So modified Reed-Sternberg cells, like first type is popcorn cell. Popcorn cells. Second type I can say we call this lacunar cells. Lacunar cells. And third is a mummified Reed-Sternberg cells. Mummified Reed-Sternberg cells. So these are what? These are modified Reed-Sternberg cells. These all are modified Reed-Sternberg cells. So if you see popcorn cells means it will look like a popcorn. So here you can see lymphocyte and histiocyte. So this is also called as L and H cells. L and H cells or popcorn cells. Lacunar is ending in AR. Lacunar. And nodular is also ending in AR. So remember, lacunar type is seen in nodular sclerosis. Mummified means there will be a frozen, more necrotic material. So more necrosis, that where we see in lymphocyte poor. So these are the subtypes that you have to remember. Is it clear? Am I clear? So remember, okay, let me make it more simple. Like every boy, they have some pain when they are buying popcorn in PVR, because in PVR, you know, the price of popcorn is very expensive. It's like 250 rupees for 10 rupees popcorn. So you all have bought that popcorn and you are having chest pain. But there is one person who will not have any pain in buying popcorn, right? That person is Ambani. Ambani can buy that damn PVR. So these popcorn cells are seen in lymphocyte predominant. So this was the last year NEET PG question. L and H cells are seen where? In lymphocyte predominant. Lacunar, nodular. Simple. Lacunar, nodular. Mummified, lymphocyte poor. So this is about your Hodgkin lymphoma that you have to remember. Am I clear? Okay, let's move ahead with the next question in front of you. Try to answer. A patient with anorexia, jaundice. So jaundice is the hint here. First hint in the question is jaundice. A right upper quadrant pain. So whenever you see jaundice and right upper quadrant pain, means they are talking about some problem in the liver or gallbladder. So came with increase in fragment of both direct and indirect bilirubin. So bilirubin is increased. Simple. So question they are making it more simple. Investigation is showing AST and ALT. Increase AST and ALT means both are increased, but they are not mentioning which is increased more. Viral screening revealed HBs antigen positive, IgM anti-HBC antibody positive, anti-HCV negative. What is the possible diagnosis? So this type of question, like what I feel many students they have issues in answering this question. So let me make this very simple. First thing is, suppose in this question AST ALT elevation is not given. So normally you can assume the value of AST and ALT they are in the range of 0 to 40. So AST and ALT normal value is up to 0 to 40. So there is a possibility you can see AST is more than ALT. Both are increased, but AST is more. Suppose I can say AST is 100, ALT is 80. So AST is more. Or I can say ALT is more than AST. So whenever we see AST is increased more, then this is suggestive of S for sharab. S for sharab means alcohol. Then the cause could be alcohol, because there are two things which affect your liver, alcohol and hepatitis. These are two important things. When ALT is more, then we will think of some viral cause. It could be viral hepatitis. Clear? So this thing first you should keep in mind, but in this question it's not given, but I want you to approach the question in a similar way. AST is more, think of alcohol hepatitis. ALT is more, think of viral. Now they sometime may give you ratio. Suppose AST ALT ratio is given more than 2:1, means both are increased but AST is increased more. Then this is suggestive of alcohol. And if I say this ratio is more than 3:1, this is definitive of alcohol. Now understand, suppose whenever a person who is having alcohol abuse, he is admitted in the hospital in front of his parents. If you are asking like do you drink alcohol, definitely he will deny. So you have to see the liver function test report. If AST is increased more than ALT and ratio is more than 3:1, that is definitive of alcohol. And if this ratio, these two are the lines of Harrison, if this ratio is more than 5:1, then this is called Maak Kasam Sharab Pita. Is it clear? So remember, this ratio is very, very important. Is it clear? This ratio is very, very important. Now here it is not about alcohol, here it's about viral screening is given. So for viral screening, what you have to remember, you have to remember certain viral markers. You have to remember certain viral markers, and how we can approach these markers, that is they ask in MCQ. So what should be your approach towards markers? So let me say, this is a question of hepatitis B, right? So I can say first thing you can remember like this, SCECES. So this is something that you have to remember, SCECES. Just say this 5 times with me, SCECES, SCECES, SCECES. So understand this, S means this is HBS antigen, this is HBC antigen, this is HBE antigen. So first three sequence of antigen. So understand this, if HBS surface antigen is positive, it means there is entry of virus. So virus entered your body. C means core antigen. This core antigen is usually not detected. When it is not detected, so not asked in MCQs. It is not detected, so not asked in MCQs. E means HBE for envelope. The virus which entered your body, this virus is now replicating. It is dividing. It is dividing means viral load will increase. If this is positive, it means this virus is replicating. Replicating means more viral load. So disease is now turning to be infectious. So this is now infective. Clear? This is now infective. Now see the antibody. Antibody means, I will write like this, antibody, anti-HBC antibody. This anti-HBC antibody, from the microbiology knowledge you have to remember this, it could be of IgM type or IgG type. Anti-HBC antibody can be IgM. IgM means this is a marker for acute infection, so this will be acute. and IgG will be marker for chronic infection. Clear? Then what we have? We have antibody. So against envelope antigen, anti-HBe antibody. Now see, HBe antigen was telling you replicating marker. Now if you develop antibody against this, it means this is now no longer replicating. So no longer replicating means it is no more infective. So this is, I can say, no more infective, or we call this as end of infectivity. And finally, if you develop antibody against surface antigen, if this is positive, then what we call this as cured. This is called cured. Clear? This is called cured. So now just try to understand this. I will make something positive, negative, and I will try to confuse you. You have to make a diagnosis. Trust me, you don't have to see the options. So try to make a diagnosis by just seeing the report. And remember this thing. Suppose in MCQ they are giving you, in the MCQ, let me write like this. In the MCQ they are giving you HBs antigen positive, HBe antigen positive, IgM anti-HBc antibody positive. Now see, first, surface antigen positive means entry, envelope antigen positive means infective, IgM means acute. So this is the diagnosis will be acute infective hepatitis B. Acute infective hepatitis B. Clear? So I am writing something in front of you once again to make this very simple. So now I will try to confuse you, but you don't have to confuse because this is a very easy topic. So I am writing here HBs antigen. HBC is not detected, so I am removing that. So I am writing IgM anti-HBC antibody, IgG anti-HBC antibody, anti-HBe antibody, and anti-HBs. So these are the values that generally they will give you in MCQ, right? Okay, so let us see. This is positive, this is positive, this is positive. Tell me the diagnosis. Try to answer, guys. Tell me the diagnosis. Entry is there, infective, IgM means acute. So diagnosis will be acute infective hepatitis B. Simple? Simple? Okay, okay. Let me remove this word. Let me remove this now. And if I say this is positive, instead of this is positive. Now see, entry is there, infective, but it is chronic. Simple? But now it is chronic. Clear? Okay, suppose this is not given. This is not given. Only this is positive. This is given. Now tell me what we call this. Entry is there, acute. So what we call this? We call this acute hepatitis B. We don't know whether it is infective or not. To know whether it is infective or not, we have to test for HBe antigen, or we need to check for viral load. That is called HBV DNA. Clear? So this is, I can say, not chronic. Gaurav, this is IgM means acute. Okay, now see, if I write like this, IgG, this will be your chronic hepatitis. Okay, so let me make it more complex. So try to answer this. What do you think what it is? What do you think what it is? Anti-HBs antibody is positive. Now you will say this is cured. To cure something, there should be entry. So this is not cured, this is vaccinated. Right? And if I say HBs antigen is also positive, then this will now become cured. This is cured. Clear? The last thing you have to remember in this is, sometimes they will give you all markers are negative, only IgM is positive. All others are negative. So remember, IgM is very fast in your body. So this will become positive before surface antigen will turn positive. This period is called window period. This period is called window period. Clear? So this is what you should remember about this question. Now let us see your question, and you have to answer this. Try to answer. So let us see what positive is given. Surface antigen is positive. IgM is given positive. This is negative, so not our concern, and that is also HCV, hepatitis C virus. So what will be your answer now? Try to answer. Yes, Ranjit, Venkat, try to answer. Bharat, Ashutosh, what will be your answer? Surface antigen is positive means entry is there. IgM is positive. IgM is positive means acute. So diagnosis will become acute hepatitis B. Acute hepatitis B. Clear? Am I clear? Acute hepatitis B. So this is what you should remember about this question, the easy way to solve this MCQ. Okay, now coming to an ABG analysis question, try to answer this. Comment on this question. Okay, to solve ABG question, you have to remember a certain rule. So first rule is, if pH and PCO2 they move in same direction, if they move in same direction, so same is having M, then disorder is metabolic. Right? They move in same direction, the disorder is metabolic. And if I say if pH and PCO2 they move in reverse direction, they move in reverse direction, so R4 reverse R4, then disorder is respiratory. So these are the two simple rules that you have to remember, right? So pH and PCO2 they move in same direction, metabolic, reverse direction, respiratory. Then what you have to see, you have to look for pH. Then you are looking for pH. If pH is low, then this is a state of acidosis, and if pH is more, we call this alkalosis. Simple. This is very, very simple. So remember the normal pH, I can say this is your 7.35 to 7.45, and normal PaCO2 value will be 35 to 45. So this is what you have to remember. Clear? This is what you have to remember. So let us see the question now. Normal value, I told you, I am writing again normal value of pH. This is 7.35 to 7.45. So here I can say pH is reduced. Normal PCO2 value is 35. This 0.35, 35 to 45. It's very simple, right? So understand this. Now you see pH value is, PCO2 is more. So I am putting an arrow, up arrow. So you can say one is going down, one is moving up. So this is what we call this. The arrows are opposite. So reverse means they are moving in opposite direction, right? They are moving in opposite direction. Now see, if pH and PCO2 both are increasing means same direction. Both increase or both decrease, this is called same direction. If one is increasing, next is decrease, that means opposite direction, opposite or reverse direction. So this you understand clearly. Here arrows are reverse, they are opposite direction. So this disorder is respiratory. So disorder is respiratory. So respiratory, then you look at the pH. pH is 7.2 means pH is decreased. So answer will be respiratory acidosis. Clear? Right? Okay, what if pH is normal and PCO2 increase? So that is a question they ask on compensation. That is the question they ask on, from past 2 years. They are not asking question on compensation. Like if you type in Google like ABG analysis, Aman Setiya, you will get a complete video on compensation part as well. So this is like a high yield topic. So I am trying to interpret the expected questions, so which is not possible here. So ABG is a big topic. So but remember, there is a 1 hour video on YouTube. If you type, you will get the video. So till now remember the simple rule: if they move in same direction, metabolic; reverse direction, respiratory. Okay. Okay, coming to next question. Drug not given in Wilson disease. Try to answer. Options are trientine, calcium, penicillamine, zinc. Anyone? I am waiting for your answer. 30 seconds. Try to answer. Saif, Ankit, Venkat, Vigneshwaram, Gaurav. Try to answer. Anyone? Come on, guys. Try to answer. Come on, try to answer. What do you think? Okay, so understand this Wilson disease is a topic which is a very important topic they ask in exam. Like we also call this hepatolenticular degeneration. Hepatolenticular degeneration. Hepato means liver. Lenticular means in the brain. What we have in the brain, we have lenticular nuclei. Right? So the drug of choice in Wilson disease is zinc. So this is not the answer. Then what we can use? We can use chelating agent. So D-penicillamine we use, but it is a highly nephrotoxic drug. So nowadays we are using trientine. Calcium is having no role. So just I am writing here zinc, D-penicillamine, trientine, and there is one more drug, and what Harrison says, like in future that will be the future drug of choice, that is called tetrathiomolybdate. Tetrathiomolybdate. So these are 4 drug options out of these. So these are the drug option available in Wilson disease. So these are the 4 drugs we have. Calcium, there is no role of calcium. Now understand, Wilson disease, they always ask a question. For this I want to show you something. Just look at the screen carefully. This is copper. This is copper, right? So this is a passenger. You can see copper is a passenger, and this is a bus. The bus name is ceruloplasmin, right? The name of driver of the bus is ATP7B, and this bus will depart tomorrow afternoon 1 p.m. So understand this, with this understand this, just try to understand this concept. Wilson disease is a disease. So what you can see here, the driver name is ATP7B, and this is an autosomal recessive condition. So there is ATP7B gene mutation. So what happened? This bus is missed. So there is decrease in which protein? Copper transporting protein. That copper transporting protein is ceruloplasmin. So this will affect copper transport. So copper transport is affected. Clear? So ATP7B gene mutation, autosomal recessive condition, deficiency of ceruloplasmin. What we get? And the defect is at chromosome. What is this 13? This 13 is chromosome. So chromosome number is 13. So these are all MCQs. Now here I want to tell you, like, copper is being not transported. So what will happen? Suppose you are coming to a classroom, but you miss the bus. There is no source of no resource where you can reach. So what you will do? Suppose you are going for classes, but you can't reach. So same thing is, you will do something. You will do something. So what you will do? Your exam is near, so you will study, right? Or suppose you are watching some movie or some free videos in YouTube. You are watching something, right? You are watching some motivational video or something. What else you can do? You will go back home. You will pee and sleep. Pee and sleep, right? Or you can go to a shopping mall. Am I clear? To understand this, whenever like you are doing something, you will not freely roam in the street, right? Same thing is with the copper. Copper is not being transported. So what will happen? Copper will go somewhere. So copper will go somewhere. To study, what you need? Brain. So copper will go into brain. To watch movies, what you need? Eyes. So copper will go into eyes. Or copper will go into urine. You can see increase in urinary copper. Shopping mall of the body is liver. So copper will go into liver. Simple. So just try to understand this. What are the symptoms you will see in Wilson disease? You can see the patient will have liver manifestation. So there will be cirrhosis, right? Copper is going into eyes. So in eyes you will see KF ring. You can see Kaiser-Fisher ring, or you can see a type of cataract. Which cataract you see? So there can be sunflower cataract. Sunflower cataract. You can see increase in urinary copper. Increase in urinary copper, and copper can go into brain. Copper can go into brain. So that is why sometimes you can see secondary Parkinson-like feature. So patient can develop Parkinson disease like feature. So these are the symptoms that you have to remember. And when you do the MRI, this MCQ they ask as a radiology question. When you do MRI of the brain, in MRI you will see a face of giant panda sign. Face of giant panda sign. Clear? Am I clear? So this is, you should remember about Wilson disease. So you can see all these questions they have asked. Is it clear? So this is what you should know about Wilson disease. And the treatment I told you what we have 4 options. That is zinc we can use as a drug of choice. Then we can use chelating agent like D-penicillamine, trientine, and tetrathiomolybdate. Am I clear? Okay. So let's move to the next question. Now it's the ECG based question. So now see, I know you can solve the one-liners easily. So as a medicine faculty, my job is to solve those questions which are tricky, which are controversial, which are confusing. So that is what I'm trying. Okay, so try to answer. You have 30 seconds to answer this question. Alfaz Raima, congratulations. Right, for your FMG exam, I wish you all the best. Now don't stop here. Study for PG. That's very, very important. Okay, try to answer. Gaurav, Burfi, try to answer. What do you think? A 68-year-old male admitted in ICU for acute exacerbation of COPD develops. So let me highlight the hint. Old age itself is the first hint. ICU admission, COPD exacerbation. Third hint, palpitation. Following are the ECG changes. What is the most likely diagnosis? Suppose if I know nothing about ECG, still I can mark this question. Let's see how. Now first you can see the ECG. If I zoom this ECG, you can see in the ECG there is QRS. This is the QRS. If you see QRS, this is called a narrow complex QRS. So narrow complex QRS means it is atrial pathology. Clear? Narrow complex QRS means atrial pathology. Then you can see this is AMI, means acute myocardial infarction. Can you see any ST elevation? No. So MI is ruled out. Ventricular tachycardia are always broad QRS, so it is ruled out. And here what we can see, we can clearly see P waves. You can clearly see P waves. P wave is present. So you can clearly see P waves. In atrial fibrillation, P wave is absent. So even if I don't know the answer, I made the answer correct by ruling out. The same thing you need to do in the exam. Clear? So let us understand this, how to solve a question on arrhythmia, because like a NEET PG paper, what I am seeing from past 3 years, they are asking question or ECG based question only on arrhythmias. So understand this, there can be, first thing you have to look for QRS. So QRS can be narrow or it could be broad. So always remember, narrow QRS is also considered normal. So when I say QRS can be narrow or normal, so narrow QRS means this is an atrial pathology. Right, atrial pathology, atrial, sometimes we can use the term supraventricular. And broad QRS, broad we also call this wide QRS. So this is going to be ventricle pathology. Simple. So QRS can be narrow, atrial. Once you see this, you will straight away go for RR interval. So what you can see in RR interval, if RR interval is regular or RR interval is irregular. RR interval is irregular. When we see RR interval is regular, means every R is coming in after same number, you will see same number of box. So when we see R interval is regular, what we call this? We call this PSVT, paroxysmal supraventricular tachycardia. If RR interval is irregular, if it is irregular, then you have to see P wave. So P wave, so again two possibility. First is you can see more than 3 different type of P wave, or there is no P wave. If you see more than 3 different type of P wave, this is what we call this as MAT. MAT means multifocal atrial tachycardia. And if there is no P wave, we call this atrial fibrillation. So this is about the narrow QRS algorithm that you have to remember. Coming to wide QRS, again here you have to see the RR interval. You have to see RR interval. So again RR interval can be regular or RR interval can be irregular. When we see RR interval is regular, we call this VT. VT means ventricular tachycardia. And if you see RR interval is irregular, then what we have to see? Here we are seeing QRS. So again same thing, you are seeing more than 3 type of QRS, somewhere small, somewhere bigger, or what you are seeing a question mark on QRS. Question mark means unidentifiable QRS. So when we see more than 3 type of QRS, we call this torsades de Pontes. And when you see no QRS, what we call, or unidentified QRS, we call this ventricular fibrillation. So this is the algorithm that you have to remember. Clear? So in this ECG, let us go back to the ECG. So I want you to take a screenshot of this or see this part of the video again, because it's very, very important. This will help you to solve one question in exam. So let us see the ECG. You can see clearly in the ECG. It is narrow complex, so it is atrial. So atrial, I told you three differentials. MAT, it could be PSVT, it could be AF. P wave is there, so AF is ruled out. Now see the RR interval. Is it regular? No. Right? RR interval, see once again. RR interval is somewhere it is bigger, somewhere it is smaller. So RR interval is irregular. So when it is irregular RR interval, you should know this is not PSVT. So when MCQ is giving you hint, you can see different type of P wave. The arrow they are mentioning, this you can see it look like P pulmonale. So this type of changes you can see there are more than three morphology of P wave. We call this MAT. Right? And the classical hint is like MAT is a condition, it's a type of arrhythmia. Which drug you will give in MAT? Who will answer me? Try to answer. Jack Sparrow. Which drug? Which antiarrhythmic you will give in MAT? Which antiarrhythmic you will give in MAT? Come on guys. Any guesses? बताओ, कोई तो बताओ. Gaurav, Ashutosh, Jack Sparrow, Venkat, try to answer. Which antiarrhythmic you will give in MAT? Amiodarone, Verapamil, Diltiazem, beta blocker, sotalol, propafenone. What you have to say? The answer is no role of antiarrhythmic. So you have to treat the COPD, and once you treat this, the patient will be automatically treated. Is it clear? So remember, the only arrhythmia where there is no role of antiarrhythmic drug is MAT. Clear? Okay, let us see the next question. Rejection of which of the following result in macrocytosis except? What do you think? Rejection of which of the following result in macrocytosis except? So here you have to remember first thing some basic information, then question will be very simple. So understand. Ion absorption will mainly occur where? In duodenum. This question came in recent INICET paper. Folic acid absorption is predominantly in jejunum, and B12 absorption is seen where? In ileum. So first thing, very basic physiology thing you should remember. Now understand this, B12 and folate, these two are causes of macrocytosis. Iron deficiency will cause microcytosis, microcytic anemia. B12 folate will cause macrocytosis. So this let us see the question first. Try to understand this. If I talk about B12, so B12 whenever you take, how you take B12? You will take B12 from non-veg food. You are taking B12 from non-veg food. This B12 will bind with R binders. These R binders are in the saliva. R binders are in the saliva. Then what you will get? You will get a B12 R binder complex. Then what we have? We have protease in the pancreas. Protease of pancreas. They will separate this B12 from R binders. So you will have R binder is separated and B12 is separated. This R binder will go back to saliva. Now B12 will bind with intrinsic factor. Intrinsic factor is coming from where? It is coming from parietal cells of stomach. Intrinsic factor is coming from parietal cells of stomach. Clear? And remember, so let me write this once again. You can see B12, we have R binders, and what we get? We get B12 R binder complex. So here you will see protease. Protease, what they will do? They will separate them. So R binder is separated, B12 is separated. This B12 will now bind with intrinsic factor, and it is coming from stomach. Which cells? Parietal cells of stomach. Now this B12 will bind with intrinsic factor, and they will go into terminal portion of ileum. In the ileum we have receptor for B12. These receptors are called cubulin receptor. Cubulin receptor or cubam receptors, and ultimately in the ileum you will see B12 absorption. This is ileum. So understand this. So basically they are trying to ask you the physiology medicine overlap MCQ. So see once again, what could be the cause of B12 deficiency? First is you are vegetarian, because B12 is coming from non-veg food. So first cause of B12 deficiency will be non-veg food. Second is you are not properly chewing the food, because this B12 is coming from saliva. So any salivary gland pathology, like there is mumps, there can be a Sjogren syndrome, like there can be some infection of parotid glands. Third possibility is you are alcoholic. So alcoholism, you will not it will lead to pancreatitis. So pancreas will not produce protease. Fourth cause is antibody will destroy intrinsic factor. This is called pernicious anemia. Fifth will be these receptors are mutated. We call this Emerslund-Grace-Bock syndrome. And then sixth, I can say, suppose there is some surgery or some infection in the ileum, like it could be a GITB, it could be ileectomy, or some adhesion or strictures in ileum. Or suppose there are some bacteria in the ileum, and these bacteria are eating all the B12. So from 1 to 7 which I have written, now I am writing the names of this. So understand, first is vegetarian diet. You are vegetarian. So suppose this is like a Gujarati guy who is pure vegetarian, not eating non-veg food. Some of you are like that. Second cause will be pancreatitis. So remember, alcoholism can cause pancreatitis, that can also lead to B12 deficiency. Third is called pernicious anemia. Sorry, this third is pancreatitis. Second will be salivary gland problem, salivary gland pathology. Fourth is pernicious anemia. Fifth, I can say this is called Emerslund-Grace-Bock syndrome. Sixth will be ileum disease. So this could be like any surgery or malabsorption. And seventh is, we call this bacterial overgrowth syndrome. Bacterial overgrowth syndrome. So these are the causes of B12 deficiency. Now what I want to tell you is, in this question, just try to understand this question. Ileum deficiency, can it lead to B12 deficiency? Answer is yes. So can it cause macrocytosis? Yes, because B12 absorption occur in ileum. Folate deficiency will cause macrocytosis, because folic acid absorption occur in jejunum. So jejunum is not the answer. Clear? If I talk about stomach, intrinsic factor is produced from parietal cells from where? Stomach. So these three are needed for both folate and B12. Duodenum is for ion metabolism. So duodenum, remember, duodenum rejection will cause microcytosis, not macrocytosis. Clear? So question was, this was an easy question which came in exam, so that you have to remember. Okay, try to answer the next one. A patient who is a known case of ischemic heart disease underwent a circumflex artery bypass. So it's like a patient who had bypass surgery. Stent is now placed successfully. He is already taking lisinopril, verapamil, metoprolol. Which drug should be added? So try to answer. Ashutosh, Prashant, Gaurav, Jack Sparrow, try to answer this question. What do you think? Which drug you will add in this patient? Okay, some of you are not knowing the name. So like all of you are familiar with PDE5 inhibitor. Any example of this? Phosphodiesterase 5 inhibitor. Yes, this is your favorite, sildenafil. Right? Okay, PDE3 inhibitor. This is like we have drug like cilostazol. So this is like cilostazol we use to treat DVT and varicose vein. A direct anticoagulant, what we have? We have direct anticoagulant like dabigatran. We have dabigatran, rivaroxaban, apixaban, edoxaban. These are direct oral anticoagulant. Apixaban, edoxaban, rivaroxaban. These are direct. Right? Yes. If your pharmacology is strong, then you already guessed the answer. P2 vital receptor blocker. This is which? This is your clopidogrel. So understand this. So this is a question, how to solve this question. So here you can see patient went a bypass. There is stent placement also, right? So this is like an indication to use dual antiplatelet drug, right? So generally what we use dual antiplatelet drugs. So basically in this patient we should add aspirin plus clopidogrel. Clear? So you should add aspirin plus clopidogrel. This is like dual antiplatelet therapy that we should add in this patient. Clear? Okay, even if it is not mentioned aspirin, so aspirin is something which is a must thing. Unless contraindicated, remember we should give aspirin. To all patient post bypass or post stenting, aspirin is something that is must. And remember, like aspirin is like kitne aaye kitne gaye. No antiplatelet is superior to aspirin. Very important drug. Okay, easy one for you. A lollipop question for you. Most common infection after renal transplant patient. What do you think? The simple answer. The most common infection after kidney transplant is CMV. It is cytomegalovirus. So CMV is most common infection. Okay, why I am keeping this question? Because suppose if instead of kidney I can write here heart, I can write here liver, I can write here lung. So I mean to say most common infection after any solid organ transplant, the answer is CMV. Clear? So most common opportunistic infection after any solid organ transplant is cytomegalovirus. And you know the cytomegalovirus is having owl's eye inclusion bodies. Owl's eye inclusion bodies. Right? These can be in the blood, these can be in the urine. Okay, now coming to a kidney transplant, just I want to mention one more thing. This renal transplant is one of the transplant which is successful. So in kidney transplant patient, the most common infection is CMV. There is an infection with one more virus which can affect kidney transplant patient. Anyone? Any guesses? Microbiology, medicine overlap. Right? We prefer clopidogrel these days. Okay, so answer, what is the other virus we can see? There is infection with a virus called BK virus. BK virus. So what is this BK virus? Understand this. It is coming in the family of polyoma virus. This polyoma virus is having two members. One is called JC virus. Second is called BK virus. Right? So remember, JC means jerky cerebellum. JC is jerky cerebellum. And BK is bad kidney. So understand this. Jerky cerebellum, bad kidney means JC virus will affect your brain. In brain, this will cause a condition called PMLE. PMLE, progressive multifocal leukoencephalopathy, and this bad kidney means BK virus. This will affect a newly transplanted kidney. So this is a rare virus, but remember the most common infection in kidney transplant patient is also CMV. Clear? This is what you should remember. Okay, coming to next question, which is not seen in ACTH deficiency. ACTH deficiency. So like this type of question you can easily solve. ACTH is a hormone. This hormone is responsible to cause hyperpigmentation. Right? So ACTH, if it is less, then there will be less pigment, there will not be hyperpigmentation. Clear? So ACTH deficiency can cause nausea, it can cause vomiting, it can cause fatigue, it can cause anorexia, right? It can lead to hypotension. Clear? And hypopigmentation. Is it clear? So this question like came in NEET PG exam as well as came in FMG exam. A similar question to this, like which hormone is called hormone of pigmentation? That is the ACTH. Okay, coming to next one. Which of the following drug is given prior to thyroid surgery to decrease blood loss during surgery? Which drug we give? Try to answer this question. So understand this. If I say thyroid gland, what we have inside this gland, we have T3 and T4. So whenever we are doing a thyroidectomy, a total or partial thyroidectomy, sometime during surgery, there is a possibility this T3, T4, these are the hormones which come into blood. They will come into blood circulation, right? And these are thyroid hormones, so they can increase your basal metabolic rate. So what you can see the patient can have increase in blood pressure, and increase in heart rate. So this is what we call this thyroid hormones are coming into circulation. We call this thyroid storm. Thyroid storm. Clear? So understand this. This is like prior to surgery, we should avoid this complication. So what we give before surgery, we give Lugol iodine or potassium iodide. Right? Potassium iodide or Lugol iodine we give to prevent this complication. That complication is called thyroid storm. So this is like a topic which they are testing again and again. Right? Okay, coming to next. Try to answer. A patient has vomiting and no proper dietary intake for 4 weeks. Vomiting is there, no proper dietary intake, means he is not eating. He has been treated aggressively with IV fluid. Which fluid? Normal saline. Following which patient developed quadriplegia and became mute. What is the correct statement? So understand this, what it is. First you try to answer, then I will tell you the reason behind this. So what do you think in this question? What is the answer? So this is like a common problem. Like in India, there are many quack practitioners. Even like I have practiced in a village, so where people are coming. Patient himself is telling like, Doctor साहब मुझे अच्छा नहीं लग रहा है, एक बोतल चढ़ा दो. Botal means NS. So understand this. Like what Harrison says, there is no point of giving IV fluid when patient can't have oral intake. अगर पेशेंट मुंह से पानी पी सकता है तो मुंह से दो उसको, ORS दो. Is it clear? So understand this. What is the problem with the quack practitioners? They give IV fluid for no reason. And whenever we want to correct sodium, so remember the normal range of sodium is 135 to 145. So excess of sodium is dangerous and deficiency is also dangerous. So if I say is 135 to 145, if you say deficiency is dangerous and excess is dangerous, suppose any person who is having vomiting, so this could be a patient, because of vomiting he can develop hyponatremia. So that is why what we give, we are giving NS, normal saline. When we give normal saline, we are trying to treat. So remember this sodium correction should not be more than 8 to 12 milliequivalent per day. This is the correction that we recommend, 8 to 12. Suppose you are having a patient whose sodium is 120. So next day you are expecting this maximum, this should be 132. Am I clear? So always remember, correction rate should not extend beyond 8 to 12 milliequivalent per day. So when we try to correct this rapidly, this sodium, this excess sodium, if you give to patient, there will be reaccumulation of osmolyte, and that will lead to that will compete with your myelin. So this is a condition what we call this as ODS. ODS means osmotic demyelination syndrome. No, you are saying anarchally in front of you and I am writing there ODS, osmotic demyelination syndrome. This when progress, what we call this? We call this central pontine myelinolysis. Central pontine myelinolysis. Osmotic demyelination syndrome, central pontine myelinolysis. So remember, this is the condition that is seen due to rapid correction of hyponatremia. So what happens is, sodium is competing with the myelin. You can see there will be removal of myelin. So patient will develop quadriplegia. There will be quadriplegia, means all muscles, upper limb, lower limb, all are paralyzed. Right? So this is like we see the patient is in a vegetative state or comatose state. He can't move the limbs, upper limb, lower limb, both are not working. What he can do is only he can move the eyes. So this is like, we call this locked in syndrome. Locked in syndrome means like अकबर ने क्या किया था अनारकली के साथ, दीवार में चुनवा दिया था. तो अनारकली कुछ कर नहीं सकती, बस इस विंडो से देख सकती है. इट इज़ लाइक सेम थिंग, पर्सन कांट डू एनीथिंग, जस्ट you can see some ocular movement, that's it. Locked in syndrome. Clear? So I hope next time you will never forget this osmotic demyelination syndrome. Clear? आगे चले. Okay, which structure will give rise to hemibellismus? Hemibellismus. So understand this. There are certain movement disorders. So first is chorea. So chorea, C for chorea. So chorea, it is like a semi-purposeful involuntary movement. This will occur. C for chorea, C for caudate nucleus. So whenever you see damage in caudate nucleus, you will get something called chorea. Chorea. The second type of movement is another involuntary movement, that is called athetosis. Athetosis. You will see athetosis whenever there is damage in globus pallidus. Globus pallidus and putamen. Globus pallidus and putamen. So how to remember this? Remember like this: globus pallidus, and I am writing a gap. Globus pallidus, G for globus, P for putamen, A for athetosis. Third movement is called hemibellismus. Hemibellismus is relatively a strong jerky movement. It's strong jerky movement, like patient is having, it's coming with force. This is like strong forceful movement. This is occurring due to damage in subthalamic nuclei. Subthalamic nuclei, you will see hemibellismus. Is it clear? So the answer for this question is subthalamic nuclei. So remember, bellismus, simple, thalamus. Bellismus, thalamus. Thalamus means subthalamic nuclei. So this is how to remember this. Easy one. Okay, next one, try to answer this question. Like I'm expecting this question again, because this is like something which is trending in practice, so they can ask you a question on this topic. Try to answer which is the drug. Diabetic patient with deranged renal function, which drug can be given? Which drug you can give? बताओ आंसर क्या होगा? Which drug you can give? SAF, reformer. Try to answer. Okay, when you see the option here, all these drugs, like first let me tell you, like glimepiride. Glimepiride is starting with G and ending in IDE. So the drugs which start with G and end in IDE, these drugs are sulfonylureas. These are basically second generation sulfonylureas. All the gliptins, linagliptin, vildagliptin, sitagliptin, these gliptins are DPP4 inhibitor. DPP4 inhibitor. So these are used in. So understand this. If you see, like out of this, all these gliptins can also carry some risk of pancreatitis. Gliptins can also, like some case reports have been seen, so they can cause thyroid carcinoma. But the one, all these need dose modification. Glimepiride we avoid. So sulfonylureas are avoided in kidney failure patient. One drug, that is linagliptin, this is considered safe in CKD. So safe in CKD and AKI. This is the expected question in this attempt. Safe in CKD and AKI is linagliptin. So if I ask you which OHA or which drug prevent AKI or prevent kidney damage, prevent nephropathy, then answer will become different. So any drug, any OHA that can prevent nephropathy. Drug means oral hypoglycemic agent. The drug which prevent kidney damage, which drug? Yes, example I can give you: canagliflozin, dapagliflozin, empagliflozin. These are SGLT2 inhibitor. SGLT2 inhibitor, they can prevent nephropathy, but if patient, in this question what is given? Patient is already having deranged renal function. So here what we prefer? We prefer linagliptin. Clear? Linagliptin. Okay, one more question on thyroid. Try to answer. 65-year-old male, old female with history of constipation. With history of constipation. Menorrhagia, cold intolerance, non-pitting edema, became drowsy and developed severe mental alteration. So like you can see, like patient is non-compliant, she is frequently missing her medication, pulse is 50, so there is bradycardia, BP is also on the lower side. What is the diagnosis? What do you think? So this is like a complication of hypothyroidism. So hypothyroidism patient, they can develop a complication, that is they can end up in mixed edema coma. So now you can see there is no heart failure. Why? Because heart failure will have pitting edema and there is no other symptom. There are no cardiac symptom as such, so heart failure is not the diagnosis. There is no sugar mentioned, so no decay. Hashimoto thyroiditis will have very minimal symptom and sometimes there is no symptom at all. So this is the case of mixed edema coma. So it's a case of hypothyroidism and patient is not taking medication. So this is what we call as mixed edema coma, right? So why we use the term coma? Because later on you will see a severe bradycardia and hypotension in the patient. This is like in the initial stage, but later on you will see severe hypotension and bradycardia in the patient. Okay, try to answer next. Next one, a 70-year-old female. 70-year-old female. What you can see? Okay, how long this session will go? How long you want? So like this, we are on the 40th slide. This one, 50 slides more. So you can see 70-year-old. So age is the hint. Severe headache. There is severe headache means patient is having huge headache on the left side of head. She gives history of bilateral shoulder and neck pain over past few months. On examination, there is scalp tenderness. What is the ideal screening test? So understand this question. Such type of question nowadays they are asking in exam. So first you should know that differential in your brain. First tell me the diagnosis, then I will tell you how to approach this case. So whenever I read the question, I want to make all the differential in my brain. So try to answer, guys. What do you think? First hint I told you is the age. 70-year-old female patient. These are two hints. Headache is there. Okay, unilateral headache, migraine, no. Every unilateral headache is not migraine. So what do you think? What is the diagnosis? First tell me the diagnosis. What do you think? What do you think diagnosis? I know some of you will answer the question if I show you an image. If I show you one image, then you will make a diagnosis for sure. Try to answer, guys. Try to answer. Anyone? ESR? No, ESR is not the answer. What else? Any other guesses? Okay, I am giving you time to answer, then I will come with the proper diagnosis of this condition. Yes, Chaitanya, very good. This is giant cell arteritis. So you can see now, this is giant cell arteritis. So first let us decode the question. Age. So I am giving you a mnemonic. First mnemonic is rule of 60. Simple rule of 60. 60 means more than 60-year-old, right? 60, more than 60 is ESR. And treatment is 60 milligram prednisolone per day. Clear? So first see the question. The hint in making diagnosis of giant cell arteritis is rule of 60. Rule of 60 means this is seen more in females and generally these females are above 60 years. Right? Second hint is you will see that ESR is very high. There are few conditions like other than this you will see a very high ESR in multiple myeloma. Here also ESR is more than 60. Here also you will see ESR more than 60. And third thing, remember the treatment. The treatment is 60 milligram prednisolone per day. So this is the rule of 60 that you have to remember. Okay, what is this? Bilateral shoulder and neck pain over past few months. Shoulder and neck pain over past few months. This is like something. What we call this? We call this polymyalgia rheumatica. Polymyalgia rheumatica. So remember, this is the vasculitis which is classically. So patient is having rheumatoid arthritis like joint pain, neck pain, and I can say some sort of rigidity, right? What we can call this? We can call this stiffness, not rigidity, stiffness. So patient, polymyalgia means multiple muscles, rheumatoid arthritis like features. So polymyalgia rheumatica is seen. So other than this, what else question they can ask you in exam is, remember giant cell arteritis is also called as temporal arteritis. We call this temporal arteritis. Then they can ask you like this rule of 60 in exam. ESR is very high. So ESR is very high in this patient. And then remember this condition is associated with polymyalgia rheumatica. Polymyalgia rheumatica. And many of these patients, they will have altitudinal hemianopia. Altitudinal hemianopia. This question came in super specialty exam, so I am writing this. This is the vasculitis that is associated with altitudinal hemianopia. And ultimately, if I say most common symptom will be headache, which is given. And if I ask you most dangerous symptom or most dangerous risk, that is, there is risk of blindness. There is risk of blindness in the patient, right? So this is what you should remember about giant cell arteritis. A very important disease they ask in MCQ. Okay, let us see the question now. CPK level. CPK means creatine phosphokinase. CPK levels, we have fragment of CPK like CPK-MM, CPK-MB. CPK-MM we use for muscle condition like dermatomyositis, polymyositis or rhabdomyolysis. In that case, we can go for CPK level. Or suppose in heart disease, MI. So CPK levels we check where? In inflammatory myopathies. Inflammatory myopathies means dermatomyositis, polymyositis, and sometimes like some pediatric condition like Duchenne and Baker muscular dystrophy. So CPK is not the answer. ANA level. ANA is used for screening for most of the autoimmune condition and especially SLE. Clinical evaluation of migraine? No. So remember, every unilateral headache is not migraine. So here what we do for screening? We go for ESR. So answer for this question is ESR. Clear? ESR. Okay, coming to next one. Try to answer. Try to answer. Madhavan, Richa, Madhavan, Rohan, Chaitanya, try to answer. 76-year-old man. So let us see the question once again. Age of the patient 76. Presented to emergency department with pain in his knee. He describes pain has been worse at evening and after exertion. So pain is more in evening and after exertion. On examination, you are seeing Haberden node. So this is, you made a diagnosis already. Haberden node, Bouchard node, these are two nodes where we see these are two nodes which are present in osteoarthritis. Osteoarthritis, right? Then you can see X-ray showing reduction in joint space, subchondral sclerosis and osteophyte formation. So what is the most appropriate treatment? So this is the case of osteoarthritis. In osteoarthritis, what we can see, you can see in the DIP, this is DIP, this is PIP. So some nodules formation. Some nodules formation you can see in the DIP and PIP. So these nodules you have to remember. So this is DIP, this is PIP. So when you see some nodules formation in the DIP, this is called Haberden node. And if you see nodules formation in PIP, these are called Bouchard node. Bouchard node, right? Just don't confuse these nodes with I can say tophi of gout, because in gout this can be anywhere. In gout what we call that tophi. That tophi can be anywhere. So this is Haberden and Bouchard node that we see in DIP and PIP. So clear cut diagnosis is osteoarthritis. In osteoarthritis what we manage? So treatment of osteoarthritis is simple, and most common joint in osteoarthritis is knee joint. So anti-TNF alpha therapy. Anti-TNF alpha therapy, this is not given. This is given for rheumatoid arthritis. Like we have abatacept, etanercept, that is used for rheumatoid arthritis. NSAID and urgent orthopedic opinion. Do you think like patient is having any signs of emergency like a swollen knee or painful knee or limb deformity or limb difficulty? So there is no signs of emergency, so there is no urgency here. DMARD, again DMARD we use for rheumatoid arthritis. So this is like simple osteoarthritis. What we give NSAID and follow up. NSAID and follow up. So like we will follow the patient for few weeks, for few months. If the pain is more severe, condition is worsening, then this patient we can recommend for total knee replacement. Then we need ortho opinion. Right now there is no need of ortho opinion because there is no as such signs of emergency in this question. Clear? So understand this. Now I want to tell you the question they can give you is knee joint. They will mention this knee joint and they'll ask you what are the differential that we see in knee joint. So what are all the differential that we see in knee joint? So remember, this knee joint is most common joint affected in osteoarthritis. Knee joint is also most common joint affected in any other condition? Yes, in septic arthritis. Septic arthritis. This knee joint is also most common joint involved in pseudo gout. In pseudo gout. So how you have to approach these three clinical cases: pseudo gout, septic arthritis, osteoarthritis. So simple rule is, in the MCQ, if they mention septic arthritis means there will be sepsis. There will be sepsis means there will be, patient will have fever. There will be a very painful swollen knee. So like question will mention like, you can't touch the patient knee. It's very swollen, painful. There is edema there, right? And you can see in the MCQ they can give you TLC is very high, neutrophils are more, total leukocyte counts. The patient is in sepsis. Calcium pyrophosphate, you will see there will be history of knee joint, and they will mention like rhomboid shaped crystals. They will mention rhomboid shaped crystals. And if nothing is mentioned, they are mentioning like a Haberden node, Bouchard node, like these two findings are mentioned. Or if nothing is mentioned, then remember the blind diagnosis will be osteoarthritis, because most common out of these, septic is rare, pseudo gout is very rare, osteoarthritis is most common. Clear? Ayush, monosodium urate crystals are seen in gout. In pseudo gout, what we see calcium pyrophosphate. Simple. In gout, what we have? In gout, what we have? Monosodium urate. In pseudo gout, we have calcium pyrophosphate. So that is the differential of knee joint that you have to remember. Clear? Okay, coming to next one. Try to answer. A 30-year-old female patient. So try to answer this. Let me highlight the hint for you. So 30-year-old with alopecia, right? She went to dermatology clinic. She is also having pain in the joint for the past 6 months, for which she is taking NSAID. There is no deformity. This line is very, very important. No deformity means we call this non-deforming. So no deformity means this is a type of non-deforming arthritis. So our patient in this question is having non-deforming arthritis. So non-deforming arthritis, you can know like rheumatoid arthritis is always having deformity, so this is ruled out. Simple. She has no hematuria or dysuria. No hematuria, dysuria means there is no kidney involvement, so there is no nephritic manifestation till now. Urine analysis is having 3 plus proteinuria. So proteinuria is there, it means nephritic. Hematuria is not there, so nephritic syndrome is ruled out, but proteinuria is there, so nephrotic syndrome is still there. Granular cast. ANA by ELISA is positive. ANA is positive. Rheumatoid antigen is negative. What is the most likely diagnosis? What is the most likely diagnosis? So understand this, rheumatoid arthritis will have RA positivity or anti-CC positivity, and there is deforming arthritis, that's ruled out. Seronegative arthropathy. Seronegative arthropathy means here a rheumatoid factor is negative. So here the mnemonic I can give you is Jaipur. Jaipur means these are the conditions. So J means JRA, juvenile rheumatoid arthritis. A is ankylosing spondylitis. So here they will mention you about spine involvement. I is inflammatory bowel disease associated arthritis like Crohn disease, ulcerative colitis. So there is no such history. GI history is not given. P is psoriatic arthritis. So they will give you in psoriatic arthritis, they will give you some history of psoriasis, like they can give you silvery scales, some nail manifestation. U is undifferentiated arthritis, and R is reactive arthritis. So seronegative arthropathy will have some additional manifestation, so nothing is given, so that is ruled out. MCTD, mixed connective tissue disorder, here you will find an antibody called anti-U1 ribonucleoprotein, anti-U1 RNP. So this is like something like MCTD is you will have 2 or more autoimmune conditions in single patient. So alopecia is there, right? Joint pain is there. There is no deformity, and you can see some proteinuria. So this is like lupus nephritis feature. So diagnosis will become SLE. Diagnosis will become SLE. Clear? So understand this. SLE, they can ask you some like recent year MCQ which I am writing here about SLE. What they can ask you in MCQ? So first question they can ask you about SLE is, in SLE you can see the involvement of certain genes. So that gene you have to remember is TREX gene. Then they can ask you in MCQ which males are at risk of SLE. So remember, Klinefelter males, they can develop SLE easily. In SLE we have some antibodies. So antibody that we use for screening purpose, and antibody which is most sensitive, this is ANA. An antibody which is very specific, most specific antibody, this is anti-Smith. So anti-Smith is specific antibody. Third antibody that is important is anti-dsDNA, anti-double stranded DNA, and this antibody is both sensitive as well as specific. Right? Okay, then remember, this SLE can be due to ship drugs. You all know these drugs, like ship is, you have sulfonamides, hydralazine, isoniazide, and we have phenytoin, procainamide. These are ship drugs. So these drugs can produce SLE like reaction, what we call as drug induced lupus. In this you will find anti-histone antibody. Anti-histone antibody. So this is seen where? In drug induced SLE. Drug induced SLE. And remember, this drug induced SLE here, male is to female ratio is 1:1. Normally 1:1. Normally SLE, I can say female is to male ratio is 9:1. But this type of SLE 1:1. Same ratio. It affects both sex equally. And this is like it's not having that brain or CNS involvement. Then I can say the treatment what we gave is this HCQ as hydroxychloroquine we can give to every patient of SLE. We can give steroid. And the new drug which is an expected MCQ, that is belimumab. Belimumab is the new drug that we have for SLE. Clear? Am I clear? So this is about the SLE that you have to remember. Like, okay, Gagandeep, which markers you are talking about? Let me know the markers which you are talking about. Then I will tell you something about those markers. Feline esophagus. So feline esophagus, nothing understand. It's a simple disease. It is like hyper-eosinophilic. There is a condition which is due to more eosinophil. So we call this eosinophilic esophagitis. A simple question, and this is easily manageable condition if diagnosed early and on time. You can treat this by steroid. So treatment for this will be steroid. And whenever you do an endoscopy, in upper GI endoscopy, you will see multiple folds. You can see multiple folds, right? This folds, what we call this as corrugated appearance. So remember, feline esophagus, this will show a good response with steroids. There is a good response with steroid, and in the endoscopy you will see multiple folds, we call as corrugated appearance. Okay, they can also ask you in MCQ like Pill's esophagitis. Pill's esophagitis. So what are the drugs which can cause esophagitis? Very, very important MCQ. What do you think, which drugs can cause esophagitis? Try to answer. Anyone? Try to answer. Jatin, Richa, and Ashutosh. Okay, Metzilo, try to answer. Metzilo, you are an LNX student. I am also an LNX student. I was a student of LN test and discussion. Or only test series, like offline test series this was. So try to answer. Yes, one is doxycycline, good one. Doxycycline. What else? OCPs can cause pill-induced esophagitis. Oral contraceptive pills. Iron supplement, iron tablet can cause pill-induced esophagitis. NSAID can cause. But I want to listen the expected question. Very important drug. Now see, these OCPs, iron tablet, NSAIDs, doxy, they will very rarely they produce. There is one drug which can cause esophagitis even in one single dose. Anyone? Come on. Try to answer. Any drug which can cause esophagitis even in one single dose. Come on, guys. No, tetracycline, no. Okay, this is the drug of, I can give you a hint, this is the drug of choice for osteoporosis. Drug of choice for osteoporosis. What is the drug of choice for osteoporosis? Come on, try to answer. Drug of choice for osteoporosis. Yes, that is bisphosphonates. So remember, bisphosphonates can produce pill-induced esophagitis. So whenever we give bisphosphonates to patient, we advise the patient do not immediately lie in the bed. So like when you take these drugs, walk for few, then only go to sleep. Walk for few minutes, then only go to sleep. Clear? So that is what you should remember. Bisphosphonates are the drugs, and this is again an expected question in exam. This you can see multiple corrugated fold in the endoscopy. This image based question they can ask you. This is an image of feline esophagitis. Feline esophagitis or hypereosinophilic esophagitis. Okay, next one. Which of the following drug is not used in treatment of rheumatoid arthritis? Try to answer. Ibuprofen is Vinayak. Ibuprofen is NSAID. Ibuprofen is NSAID. Clear? Ibuprofen is also an NSAID. Following drug is not used in rheumatoid arthritis. Try to answer. Febuxostat, methotrexate, leflunomide, etanercept. Okay, so I am writing some drugs that we use in rheumatoid arthritis. So in rheumatoid arthritis, what we can use, nowadays what we recommend, we start with DMARDs. So first drug that we start is methotrexate. So this is the DMARD of choice. So recommended doses, like either we can start with 7.5 mg, right, to 15 mg once in a week. When it is not controlled by methotrexate, we add some other DMARDs, like we can add leflunomide, right? We can add sulfasalazine. We can add hydroxychloroquine. HCQS is hydroxychloroquine, right? Older treatment, gold salt. Like this was an FMG question, but nowadays they don't ask this. Gold salt we no longer use now. And we have anti-TNF drugs like etanercept, abatacept, infliximab, right? Tocilizumab we have also used in COVID, and the new drug is tofactinib. So you can see methotrexate, leflunomide, etanercept. These two are DMARDs, ruled out. This is anti-TNF, ruled out. So answer will be febuxostat. Tofactinib is JAK1, JAK3 inhibitor. So febuxostat we used to treat gout. So let's see, like in gout, how we treat. So we have two types of presentation in the gout. We can have acute gout and we can have chronic gout. So understand this, in acute gout our goal is to make the patient pain free. So drug of choice in acute gout is NSAIDs. In chronic gout, like we are trying to prevent the complication. So our goal is to decrease uric acid production or to remove the uric acid out of your body. That is uric acid excretion, to promote uric acid excretion. So in chronic gout, what we give, we can use either a xanthine oxidase inhibitor, or we can use uricosuric drug. Xanthine oxidase inhibitor or uricosuric drug. So remember, in acute gout, we have NSAID. If there is no relief from NSAID, we can give a low dose of steroid for the shortest possible duration. We can also give colchicine, right? Colchicine. So remember, colchicine. This colchicine is used for acute gout. Now coming to chronic gout, xanthine oxidase inhibitor. We have xanthine oxidase inhibitor. An example. So here what we have allopurinol, febuxostat. So generally we recommend allopurinol. Febuxostat is reserved for those people who have a deranged kidney function, like in AKI, in CKD. In that cases, what we give febuxostat. Uricosuric drugs, we have huge list, like lesinurad. Then we can have probenecid, sulfenpyrazone. One more, benzabromarone, but nobody will ask you. So here I want to just tell you something. Look at the screen carefully. A for acute gout. So A to C. In acute gout, we use colchicine. C for chronic gout, A for allopurinol. So remember A to C, C to A. A to C, C to A. So don't confuse. Remember, colchicine we use only in acute gout. Colchicine is not used in chronic gout. Okay, sometime they will give you like what we use in case of refractory gout. Refractory gout means you have tried everything, or gout due to tumor lysis syndrome. Gout due to tumor lysis syndrome. In refractory gout or gout due to tumor lysis syndrome, what drug we use? In this, what we use rasburicase. Rasburicase, pegloticase. Rasburicase or pegloticase. This is we are using where in refractory gout or gout due to tumor lysis syndrome. Clear? Okay, coming to next. Try to answer. Okay, try to answer. Mayank, Madhavan, Zoya, Dipali, Metzilo, Vinayak, Madhavan, Richa. Try to answer this question. Okay, some of you are thinking, sir, like it is syndrome X, why you have written syndrome Z? There is one more thing, syndrome Z is also there. So it is syndrome Z. So try to answer first, give your answer, then I'll tell you what is the answer for this question. Try to answer. Anyone? Try to answer, guys. Yes, come on. A, D, C. Okay, first let's try to understand this. You all know about syndrome X, right? So this is called syndrome X. We call this syndrome X or metabolic syndrome. Right? We have syndrome X or metabolic syndrome. So understand this, syndrome X means here the patient will have sugar in the range of diabetes. So patient will be either diabetic or in the range of pre-diabetes. There will be hypertension. So patient blood pressure is more. There will be obesity. So obesity we can measure by measuring the abdominal girth. Like if I put an inchy tape like this, you can see abdominal girth is huge. Then there will be alteration in lipids. Lipids are high. So I am writing here lipids. So which lipids? So remember, first is triglyceride values are more than 150 for both sex, male and female. And if I talk about next lipid, this is HDL. HDL value less than 40 in case of male patient and less than 50 in case of female patient. So what I have written in front of you, just look at this now. What you can see here, this is called DOL. DOL means diabetes, hypertension, obesity, lipid, right? So you can see what we can see here, DOL. So to make a diagnosis, so here is the DOL in front of you. Just see this very carefully. You can see the DOL here, DHOLL. Clear? So understand this, you need 3 or more symptoms to make a diagnosis of syndrome X. You need 3 or more symptoms to make a diagnosis of syndrome X or metabolic syndrome. In syndrome X, if you add OSA, obstructive sleep apnea, this will become syndrome Z. Clear? In syndrome X, if you add obstructive sleep apnea, this will become syndrome Z. So now let us see the question and try to answer. Which of the following is not a component of syndrome Z? So obstructive sleep apnea is seen. Yes. BP more than 130, it is seen. Yes. Triglyceride more than 150. Yes. LDL, no, LDL is not a part. Remember, HDL is a part, triglyceride is a part. So in lipid, remember, LDL is not the part. Am I clear? So remember, this is LDL more than 100. LDL is not a part at all. So HDL is either low or triglyceride is more. These two lipids are component of syndrome X and Z. So I hope many of you made this mistake, but so this should not be repeated in exam. So remember this rule. Simple. Okay, let's move to the next one. A middle-aged man present with frontal bossing, large tongue, spade-shaped hand. First tell me the diagnosis, only then you can tell me. No logic, no logic is needed to make a diagnosis. First tell me the diagnosis. Just don't jump into the answer. In NEET PG you have negative marking. So first tell me the diagnosis. Frontal bossing, large tongue, macroglossia, spade-like hand. So diagnosis for this case will be acromegaly. Acromegaly. For in acromegaly, what we do? Do we check for thyroid hormone? No. Serum prolactin is for prolactinoma, so nothing. Serum testosterone is for either hypoandrogenism or hyper. So answer is IGF-1 level. Clear? So this is the diagnosis for acromegaly. In acromegaly, for screening, what we do? We do a test called IGF-1 level, insulin-like growth factor 1 level. And for confirmation, we do OGTT, oral glucose tolerance test. So after this OGTT, we will measure the level of growth hormone, right? And to see the tumor, to localize the tumor, what we can go? We can go for an MRI brain, because the most common cause will be a growth hormone secreting adenoma. So for that, what we need? We need MRI brain. So I'll show you a case. This is like my patient. You can see this is my patient. Her age was 24 years. So I have clicked the photograph from the photograph. From my phone to the photograph. So he was 24 years. In 3 years, now you can see 27-year-old. In 3 years, you can see the changes. What you can see the first change? You can see the first change. This is a real patient which I am showing you. And remember, before taking such photographs, don't try to do this. Take the permission of the patient. So I have taken the proper consent and permission. That's why I am showing you this photograph. So you can see the frontal bossing. You can see the frontal bossing. Then you can notice, you can see muscular feature. You can see a prominent nose. You can see some acanthosis nigricans like feature. You can see like this female is having a little mustache here, right? You can see a prominent lips, a male like feature. So how we approach this case? You can see this patient, you can see the thickening of the pulp of the fingers, right? So these are very thick fingers. If you notice here, this is in the x-ray, if you see the heel pad thickness will be more, heel pad thickness is more. So these are the things that we see in a patient of acromegaly. Clear? So diagnosis is acromegaly. How we test? IGF-1 level. Okay, now try to answer. Question number, next question is middle-aged man. So I am highlighting the hints for you. Middle-aged man, after quarreling with his brother, suddenly collapsed and tails down. He was immediately shifted to hospital and was declared dead. What is the cause? Try to answer this question. What do you think? What do you think? What is the answer for this case? Okay, now see this question. Like when you see the sudden death, remember it's always not HOCM. So understand this. Quarreling means this quarrel will produce stress. Stress means this is an emotional drive. So because of emotions, you can see there is a release of norepinephrine in your body. So that is like a stress-induced cardiomyopathy can occur sometime in patient. Like many people in COVID die because COVID, like it was like a social phobia to everyone. There was a huge stress in society. COVID have also led to many cases of Takotsubo cardiomyopathy. So this Takotsubo cardiomyopathy is also called as stress-induced cardiomyopathy or broken heart syndrome. Broken heart syndrome. And generally you can see it is more seen in females, because females, they have more emotional component. This is generally seen in elderly females. It is generally seen in elderly females, and you will see octopus jar heart. So recent research, like I was reading an article, it was saying like Takotsubo cardiomyopathy generally is seen in females, those who are above 55 years, and these are those females whose children are not picking their phones. So like mother is waiting, calling you, and you are not picking the call, and she is like she's having huge stress. Her body is having release of catecholamines. So next time when your mother is calling you, pick her call. Right? Takatsubo, cardiomyopathy, and important cause, or daily try to call her. Octopus, jar heart, broken heart syndrome. Yes, all these are names, synonyms. Okay, why not answer is HOCM? In HOCM, you will see the stress is like some sort of physical stress. You will see banana shaped chambers, and generally, there is no mental stress here, physical stress. MI, again, MI can also occur due to stress, but there is sudden death in MI only seen when the patient can develop ventricular tachycardia or ventricular fibrillation, which is not mentioned. DCMP will have a low ejection fraction, and there will be like slow death. Sudden death is very rare. Clear? Okay, next question, try to answer. A known diabetic and hypertensive patient was found unconscious in the morning on the road with BP. You can see the BP is 180 by 100. Patient is known diabetic, known hypertensive. Pulse is 120. Pulse is 120. Bilateral plantar extensors. What is the next step? Okay, so Ayush, titin defect, genetic defect, generally what we see in DCMP, right? So if I talk about like genetic defect in DCMP, you can see the defect in titin. In HOCM, you can see the defect in beta myosin heavy chain, right? Beta myosin heavy chain. So these are some genetic defects, and DCMP is generally due to alcohol. Okay. So what is the next best step? These type of question actually they are confusing to students. Now see, imagine this in your brain and think of solving this question. Diabetic patient, hypertensive, found unconscious, right? What you will do next? Suppose this patient is now, somebody is taking him to hospital. What you will do now? You will order CT scan. Yes, we will order CT scan later on, but before this we should confirm maybe this patient is becoming unconscious because of hypertension, like it could be hypertensive bleed, it could be like sometime a complication of hypertensive, like those patients who are not taking medication on time, they can develop a syndrome called PRES, posterior reversible encephalopathy syndrome. Or it could be a complication of diabetes, like diabetes itself can produce stroke, hypertension can produce stroke, it could be hemorrhagic or it could be a thrombotic stroke. But remember, before ruling this, immediate reduce BP with antihypertensive, no. Whenever you are suspecting stroke, in stroke we never do this, so this is not the answer. CT scan we will do, but let's see the option. Mannitol we give whenever there is some sort of cerebral edema. So for that, what we need a fundus examination. So again, this we will give, but later on. Right now, what we should do, first check blood glucose level, because there could be in diabetic patient, I can say here, suppose a diabetic patient is having LOC. LOC means loss of consciousness. So what are the three possibilities? First possibility is, this is the diabetic patient who is having diabetic coma, like it could be diabetic non-ketotic hyperosmolar coma, right? Second possibility is this patient, he is having diabetes, so he is having some sort of stroke. It could be like a brain hemorrhage or hemorrhagic stroke or ischemic stroke. Third possibility in this patient, what can be? It could be like, suppose this patient at night he have taken excess dose of insulin, or he have taken excess dose of sulfonylureas. So patient is right now having hypoglycemia, and hypoglycemia can also produce loss of consciousness. Simple. So first thing is you have to rule out, because you can notice clearly here, sugar level is important. If it's hypoglycemia, suppose now when you check the sugar, if sugar level is coming like less than 70, 30, 40, 50, it means it's hypoglycemia. If sugar level is coming very high, like 50, like 500 or 600, it means patient is having due to diabetes, or it could be stroke. So CT scan we will do definitely, but later. Mannitol we will give definitely, but later, right? Immediate reduction of BP is never recommended. So first this, you should check blood glucose level. Simple. Okay, try to answer. Patient of chronic stable angina is having sign of heart failure. Chronic stable angina, sign of heart failure. What you will do next? Following drugs will increase longevity. following drugs will increase longevity? So that is you should understand. Try to answer. Which drug will increase longevity? Anyone? Ayush, Abhishek, Zoya, Zoe and Richa. Try to answer. To understand this, patients having angina and heart failure. So understand this, generally what we see whenever there is heart failure, so nowadays we have different categories of drugs that can prevent heart failure. So one is called ARNI. ARNI is angiotensin renin neprilysin inhibitor. So this is like a combinational drug. So what we have here, we have sacubitril and valsartan. This is one category of drug that can increase the lifespan. Then if ARNI is not in the option, then we have to choose ACE inhibitor. So ACE inhibitor, you know, they all are ending in pril. After this, remember, the third superior drug is ARB. So I am writing this in a sequence. ARBs. ARBs means they will end in sartan. Telmisartan, candesartan, olmesartan, right? Azilsartan. These are sartans. So these are the sequence. Now see, ARNIs everybody can't afford. Like we have a brand name Vimada in India. So, but the price is huge, so many people they can't afford. But ACE inhibitor, almost all people are affording this. Sometimes they can produce hyperkalemia, they can produce dry cough as side effect. So in that case, we switch to ARBs. So remember, sequence is the best is ARNI, second is ACE inhibitor, third is ARBs. But here it is given stable angina. In that case, only in that case, heart failure due to angina. In that case, remember, beta blocker can also improve longevity. Remember, if this angina is not given, then there is no role of beta blocker. So let us see, torsemide, right? Furosemide, torsemide, this is loop diuretic. Diuretic will not do this. Digoxin will not improve. Nifedipine is CCP, it will not improve. So answer will be lisinopril. Answer will be lisinopril. Okay, earliest feature of Parkinson disease. Try to answer, guys. Quickly, just quickly. It's an easy one. Easy one, quickly. Try to make mistake here, but don't repeat this mistake in your exam. Try to answer. Madhavan SGLT2 inhibitor. Understand this? What Madhavan want to say? This is SGLT2 inhibitor. SGLT2 inhibitor like canagliflozin, empagliflozin, dapagliflozin. These are the OHA, oral hypoglycemic agent, and they are approved to prevent heart failure. So this also we can use in non-diabetic patient, right? So remember, SGLT2 inhibitor they can also, but remember they will not increase the longevity per se. They will prevent heart failure. Is it clear? So this is like SGLT2 inhibitor. Remember this point. Like this also, even patient is having diabetes or not diabetes, we can use canagliflozin, empagliflozin in treatment, in prevention of heart failure. So that is ejection fraction will not further reduce. Earliest feature of Parkinson disease, like many of you are answering tremors, I know this is the wrong answer. So remember, like when you see Harrison, there is a Braak staging. As per Braak staging, like what they say, the root cause of Parkinson start with somewhere else, like maybe in the gut, in your brain, then it further move upward. So earliest feature which is unnoticed, that is anosmia. So this is the mistake which I want you to make it here. I know many of you are answering this as tremor, but remember the earliest feature as per Braak staging is anosmia, but this feature get unnoticed for many years. Unnoticed for many years, then later on after few years you will see the patient can develop tremors. Clear? Tremors. Okay, coming to next one. A patient with diabetes mellitus for past 5 years, present with vomiting, abdominal pain. He is non-compliant with medication and appear dehydrated. Sugar is 500, ketone bodies are present. What is the next step in management? So understand this. So first try to make a diagnosis. You can see blood sugar is 500. So again, two possibilities. It could be diabetic ketoacidosis, coma. So DKA. To make a diagnosis of DKA, the patient should be having diabetes and sugar status. Sugar should be in the range of 300 to 600. Sugar will be in this range. Ketone bodies are positive. So ketone bodies are present. And A for acidosis. Acidosis means if you see the ABG, the pH will be decreased, means acidic pH. So to make a diagnosis, how much feature you need? All three are needed to make a diagnosis. So you cannot call this DK if even any single feature is missing. So to make a diagnosis, the patient should have high sugar, urine body should be positive, pH should be acidic in nature. So here now see, patient is having vomiting, abdominal pain. These are the symptoms. The most I can say, you can see sometime like a glucometer, they are not having capacity to record the high blood glucose, so they will write high. High means HIGH. It's not high. HIGH means high blood sugar. So blood sugar is above, beyond 600, because many glucometer they have a reading capacity of only up to 600 milligram per deciliter. So when I say DK, so you made a diagnosis of DK, you need all these three things. So suppose a patient is having diabetes. What happened to him and what is the thing that triggered the DK attack? So first thing is non-compliance. Non-compliance means patient is not taking it. It's very common thing in India, like you start patient metformin, after a few years he'll stop taking it. So non-compliance medication. Second, it could be like any infection, like in COVID we had a lot of patients with DK. Any infection can produce DK. Third thing would be, suppose a person who is taking medication on time is not having an infection, but he made a road traffic accident trauma. So these are three common triggers. Like why a normal person is having, he's a diabetic, but suddenly he developed attack of DK. So what happens? Three possibility: either he's not taking medication, or he develops some sort of infection, or he met a trauma. These are three common triggers. Clear? These are three common triggers. So whenever we see like DK, you can see how to manage this. So first job is not to give insulin. First is you have to flush the body with IV fluid. Clear? So answer here is IV fluid plus regular insulin. Regular insulin is the only insulin which we can give IV. So that is why we give regular insulin. Clear? So answer will be C. Long acting insulin we don't recommend. Simple IV fluid is C is a better answer than B. Suppose if I say in this question, C is not given. C is not given and you have to choose between, suppose options are like this. And if I hide this, suppose this option is not given. Now what you will choose? Now answer will be IV fluid. Clear? So remember, now answer will be IV fluid. So I can say here, insulin of choice in emergency. In emergency means in DK, in coma, so in diabetic coma or in DK. So what we give, bioavailability of IV drug is 100%. So we have only one insulin that we can give by IV route, that is regular insulin. Right? Okay, so understand how we give insulin dosing. So suppose any person is coming to you with a very high blood sugar, be it coma, be it DK. How we manage? First is what we give IV fluid. Which IV fluid? NS. Right? So first what we give 2 to 3 liter of fluid, stat, bolus. So what we use, we give first fast bolus of IV fluid. So this is the management of both DK as well as coma. Right? First we give IV fluid bolus 2 to 3 liter. Then what we do, we continue this at the rate of 200 ml per hour. 200 to 300 ml per hour. We continue IV fluid. Plus what we add insulin. Which insulin? Regular insulin. And how we are giving this? We are giving this IV. So IV dose is, it is 0.1 unit per kg stat dose. Per kg stat dose means my weight is 80 kg. So in my body, how much you will give? 8 units. Clear? So 0.1 unit per kg. Regular insulin, I am telling you IV route, not subcutaneous, IV. So suppose I can say if the weight is 60 kg, then you will give how much? You will give 6 unit. This you are giving stat, right? Then once you do this, then what you do? We continue IV fluid and insulin. We continue this via infusion pump, right? So we are continuing both the thing by infusion pump. Some, like in many hospitals, like infusion pump is not available. Then what we add 50 unit of insulin in one NS and give that slowly. So we give this via infusion. When as soon as you can see the blood sugar, when blood sugar is reaching, it's coming less than 250. In this case, what we need to add? We need to add a neutralizing drip. That neutralizing drip is IV fluid, DNS or dextrose. So this is what we are giving, a neutralizing drip. Neutralizing drip. So now understand this, you are giving so much insulin. You are giving like insulin by infusion, so per day like it can be 50 units, sometimes 100 units. In that case, remember, insulin is having a tendency to cause hypokalemia. So a third thing what I can add is, you should always add KCl. So we add KCl. The fourth thing is what we can add, patient can have acidosis, so we can also add soda. So this is I am writing plus minus, soda bicarb. Clear? Soda bicarb. So this is how we treat, and as soon as like a patient regain appetite, we can switch from regular insulin to subcutaneous insulin. Am I clear? This is how we manage DKA. Any doubt? So insulin dosing is 0.0 unit per kg stat. Okay, one more thing I can tell you here is, like I want to tell you here, like they sometimes ask you the question on types of insulin. So remember, we have long acting insulin, we have intermediate acting insulin, and we have short acting insulin. Long acting, intermediate acting, short acting insulin. To understand this, short acting insulin will include Lispro, Aspart, Glulysin. Intermediate is your NPH and regular insulin. Long acting is Glargine, Digludec, Detemer. These are long acting. So understand this, how to remember, look at the screen carefully. Short acting insulin is having S. All short acting insulin is having S in the spelling. Long means large. So large, L-A-R-G-E somewhere here. And what is long? Long is distance. So long distance, D for distance, D for digludec. Out of this, only insulin that is IV is regular insulin. Others are subcutaneous. Simple. Okay, DK versus understand this HHS, how we differentiate this. So the only differentiation feature is, in DK you will see slightly less dehydration. In HHS or coma, what we see, you will see more dehydration. So you have to increase the IV fluid, that's it. So when you are giving, like suppose you are giving 200 ml in case of DK, you have to give 400 ml in case of coma. So there is more dehydration there, so you have to give more fluid in coma, that's it. Otherwise treatment is same for both. Okay, CSF examination, mononuclear cells, increased protein, low sugar. What is the diagnosis based on cytology? So understand this question. If I say low sugar, so first thing, remember a concept, bacteria love glucose. Bacteria, they love glucose. So what bacteria will do? They will eat all glucose from the CSF. So CSF glucose will be low in bacterial meningitis. Clear? So these two options are ruled out. Fungus and virus, they are ruled out. Virus and fungus, they don't like glucose. Now you can see TB is also bacteria. So here you can see this is called cobweb CSF. This type of CSF is called cobweb CSF, and where we see cobweb CSF, we see in tubercular meningitis. Simple. In tubercular meningitis. So remember this concept, bacterial meningitis, glucose will be low. So here just I am writing here, like CSF analysis, they will ask you cells, they will ask you glucose, they will ask you proteins, they will ask you pressure. So we have differentials of meningitis, understand this. So first is bacterial, second is tubercular, and third is viral. So protein pressure will increase in all meningitis. So what I am doing, look at the screen carefully. Protein pressure will increase in all. Right? Bacteria, they love glucose. So in bacterial meningitis, glucose will decrease. TB is also bacteria. In virus, this will be normal. Simple. In virus, this will be normal. Now see, cells means bacteria means what cells you will see? You will see polymorphoneutrophils. TB is a chronic infection, so you can see some lymphocyte. Right? And sometimes you can also see PMN. In viral, you will see only lymphocytes. So remember, whenever you see solve a question of meningitis, just remember this concept. In viral, glucose is always normal. Clear? So this is about the CSF finding that we see. Okay, try to answer. A female patient with nausea, photophobia, phonophobia, headache came to you. What drug you will give for treating this attack? So you can see unilateral headache, it is not mentioned. So just I am writing here. It is pulsatile. It is always moderate to severe, never mild. Right? So a person who is having a unilateral headache which is pulsatile in nature and moderate to severe, never mild. And this headache, I can say this is aggravating on movement. Aggravating on movement. There can be photophobia, phonophobia, and there can be nausea and vomiting. So ipsilateral unilateral headache, pulsatile in nature, moderate to severe and aggravate on movement. So to make a diagnosis, remember migraine diagnosis is clinical. So we need any two feature from here, any one feature from here, any one. So you can see nausea is there, photophobia is there, phonophobia is also there. So this way we can make a diagnosis. So in migraine acute attack, what we give sumatriptan. So drug of choice in acute attack is sumatriptan. Flunarizine topiramate, can we use this in migraine? Yes, we can use this, but these are used in prophylaxis. In prophylaxis we can use this, but remember in prophylaxis the drug of choice is a beta blocker. Flunitrazepam is called date rape drug. This is like a date rape drug. So this is like you are putting this drug in the drink of a female and then raping her. That is flunitrazepam. Right? So this is what you should remember about flunitrazepam. Okay, that is the feeling, like those people, those who are having migraine, they can realize when this migraine headache, this last one more feature here it is. So I am writing here, this headache will last from 4 hours to 72 hours. So duration of this headache is 4 hours to 72 hours. So this is a longer headache. So you need any two feature from here, from this list, any one here, any one from here. So photophobia, phonophobia, any one. So understand this. We have two new drugs for the migraine. First is like G-pants we can use. G-pants. So we have Ubro G-pant, Reme G-pant. So these are G-pant we can use in migraine. Then we have some monoclonal antibodies like Ernumumab that we use to treat migraine. So this is about the migraine that you should remember, right? Okay, pound criteria, Muzammil, now we don't use, now we use clinical criteria. This is the criteria based on Harrison, right? And now to make a diagnosis, we use this criteria, and to prognosis, we have Midas questionnaire. For prognosis, what we have Midas questionnaire. So just I am writing 3 headaches differential in front of you. Like in last PG paper, they have asked the question like a person who is taking NSAID for headache, and he developed headache after taking this medication. That headache is called medication induced headache or headache medicamentosa. So sometime remember, the drugs which we use to treat headache, they themselves can precipitate headache. That is called medication overuse headache. So we have tension headache, we have migraine, and we have cluster headache. So these are the 3 different types of primary headache. So we will differentiate these 3 different types of headache one by one, so that you will get an idea how to solve the question. So first is tension headache. If you ask me site of tension headache, so tension headache is like a band-like sensation. So it will be like a band in the entire head, right? Okay, some questions are there. Prophylaxis for migraine. For migraine prophylaxis, what we use? Okay, let me write here migraine First, let me talk about this treatment and PX. PX is prophylaxis. So in migraine treatment, what we give, we prefer to give triptans. We can also use NSAID, right? Non-steroidal anti-inflammatory drugs, and we can use Gepants, which I just told you. Gepants means Obrogepants, Remigepants. For prophylaxis of migraine, the drug of choice is non-selective beta blocker propranolol. So drug of choice is triptans here, drug of choice is propranolol. In migraine prophylaxis, you can also use some other drugs. Like in migraine prophylaxis, we can use topiramate. We can use CCBs like flunarizine, cinnarizine, right? We can use verapamil, right? We can use diltiazem, we can use propranolol, we can use TCA, tricyclic antidepressant. So these are the drugs that we use for prophylaxis. Even a type of toxin we use, that's called ona-botulinum toxin. Ona-botulinum toxin. So this is, you have to remember, the drug of choice for acute attack is triptan, for prophylaxis is propranolol. Okay, so let me see. Okay, trigeminal neuralgia, what drug we use? In trigeminal neuralgia, so I am writing here, in trigeminal neuralgia, what we use carbamazepine. So carbamazepine is the preferred drug for trigeminal neuralgia, right? Yes, for prophylaxis, drug of choice is propranolol, right? Okay. Headache medicament, that is drug induced. Any other doubt, guys? Okay, so I was telling about the differential. So migraine headache is hemicrania, or I can say unilateral headache in half side. Cluster headache, this is peri or orbital, peri or retroorbital. So first is site, you should know. The second question they ask about is tension headache. The cause of tension headache. So what is the cause? The cause is endogenous depression. Endogenous depression is the cause for tension headache. In migraine, we have multiple hypotheses. So out of this, the most accepted hypothesis is CGRP, calcitonin gene related peptide. This is CGRP is involved in migraine. We call the CGRP hypothesis. Like previously it was like nitrogen neurons, but now, or nitric oxide containing neurons, but now what we have, CGRP. Clustered headache is due to visceral hypoxemia. It is due to visceral hypoxemia. Okay, then remember when you tell a tension headache patient, let's go to play cricket, or let's go for shopping, what happens, that headache will disappear, right? So this is like, I can say, easily distractible headache. Easily distractible headache. Distractible means this is easily distractible with the things which we like, because when we do the things which we like, a body will release endorphins, right? So this is easily something easily distractible, right? So I am writing here distraction or not. But if you tell the migraine patient, come on, let's go to play cricket, he will say no. So this is not distractible. It is not distractible. And when you tell the cluster headache patient, come on, let's go to play cricket, let's go to shopping, they will definitely slap you, because this is something which is very, very severe. This is very severe. So this patient will tell you, don't take me to shopping, take me to hospital. Clear? Okay, fourth is like if you ask about the nature of headache. Nature of headache. So tension headache, remember the nature is, this is always a mild type of headache. Migraine is never mild. Migraine is either moderate or it is severe. But cluster headache, remember, this is having explosive onset. Explosive onset. So if I ask you the drug of choice for treatment part and drug of choice for prophylaxis part, so tension headache, how you will treat? So generally understand how we treat. We treat this, we treat the acute headache. So how we treat? We treat by NSAID, and the preferred NSAID is naproxen. So we give generally naproxen 250 to 500 mg twice a day. For prophylaxis, generally we give in chronic headache. In chronic headache, what we give? We give TCA. So chronic means when patient is having more than 15 episodes in a month. Acute means less than 15 episodes in a month. In migraine, I told you the drug of choice in acute attack, what we recommend, triptan, and for prophylaxis, what we give, propanol. In cluster headache, the treatment of choice is oxygen. Yes, oxygen. Or if oxygen is not, like this question came in last to last INICT paper, we can also give 6 mg subcutaneous sumatriptan. But remember, the first drug is oxygen, right? In prophylaxis, what we can use CCB, calcium blocker. Am I clear? Post herpetic neuralgia, Kishore, here also we use carbamazepine. And nowadays what we prefer oxcarbazepine is preferred than carbamazepine. Clear? Menstruation, contraceptive, wine, they all can precipitate migraine. They all can precipitate. Clear? So this is about the differential of primary headache that you should remember. Okay, try to answer. Female patient with negative pregnancy. Pregnancy is negative. Present to you with galactorrhea. MRI suggestive of large pituitary mass. Patient is not willing for surgery. So ideal answer for this question, without seeing the option, the answer for this question is cabergoline. Why cabergoline? Because cabergoline we use in non-pregnant population, and even like researchers says cabergoline will shrink the tumor size. So it's a case of pituitary adenoma, right? And galactorrhea is there, so it's a case of, so diagnosis will be, it's a case of prolactinoma. So understand this, prolactinoma, whether it is a microadenoma or macroadenoma, what we recommend to give cabergoline. Cabergoline will shrink the tumor size. But cabergoline is not given in the option, so alternative what we give bromocriptine. Clear? So answer will be bromocriptine. Am I clear? So the treatment of choice, if you ask me in this condition, that will be a surgery. That surgery is called transsphenoidal resection. Transsphenoidal resection. This is the treatment of choice in case of prolactinoma. Okay, next question. What you can see here, a diabetic patient comes to your OPD, wishes you namaste, like this. But you can see he cannot properly do the namaste. This is called he cannot do like this because there is some sort of flexor contractures here, so he cannot properly fold the hand. This is because a diabetic patient, because of chronic neuropathy, you can see deformity in the hand, that is called chiroarthropathy. So this is a chiroarthropathy which is classically seen in diabetic patient. Am I clear? Kishore, both are not, cabergoline is avoided in pregnancy. Cabergoline is avoided in pregnancy. Bromocriptine is marked safe in pregnancy. Clear? So ideal answer for this question should be cabergoline because negative pregnancy test. But cabergoline is not given the option, then answer will be bromocriptine. So normally in prolactinoma, what we give? Cabergoline. Pregnant population, what we give? Bromocriptine. Simple. Okay, answer this. Chronic alcohol patient with CLD, chronic liver disease. Chronic liver disease means cirrhosis. Sudden onset hematemesis. Now see, in all these 4 options you can see they can have hematemesis. But this is the hint in the question, cirrhosis. So you know cirrhosis patient will have portal hypertension, and because of portal hypertension means hepatic portal venous gradient will be more. So when it is more than 15, you can see the patient will have formation of varices, and varices can present to you with hematemesis, right? Varices can present with hematemesis. And remember, this will always, whenever you will see esophageal varices, portal hypertension can produce varices, it can produce ascites, it can produce hemorrhoid, sometime it can produce something called caput medusae, that is periumbilical vein will be distended, So this is like many of you are answering this as Mallory-Weiss syndrome. So Mallory-Weiss is not the answer, because Mallory-Weiss is something like which you will have after on your 5th March. Once you give the exam, then you are drinking alcohol, some of you will drink more, then there will be just M for Mallory-Weiss, M for just a mucosal tear. So maybe on the 6th March, few students will have vomiting with blood, and after like in 1-2 days it will be sorted out. So it is like just a mucosal tear, no treatment is needed, self-limiting condition. Perforation peptic ulcer. So here there will be history of abdominal pain, which is not given in the MCQ. There should be like X-ray finding suggestive of gas under diaphragm for perforating peritonitis, which is not mentioned here. Boyer-Haave syndrome, on the other hand, in this it's like a transmural. It is something transmural. So you can see all the esophageal content will rupture. They will go into mediastinum. So when they go into mediastinum, patient can develop subcutaneous emphysema, or we call this pneumomediastinitis, and we get a sign called Haman sign. Haman sign means on auscultation you will have a crunching sound. So remember, this Boyer-Haave is also an acute condition. Malravi is an acute condition. Here the hint is cirrhosis. So this is a case of esophageal varices. Yes, in real life, migraine and cluster headache can occur together. They both can occur together. They both can occur together. Am I clear? So many people, they have tension headache with migraine. So both you can see overlap of headache easily. Okay, next. Best drug for urate lowering therapy in tumor lysis syndrome. I told you this thing, now you have to answer. I told you already when I was telling you the differentials of buxostat MCQ. I told you this. Try to answer. Try to answer this question. Divya Jyoti, Richa, Anne Mary, Madhavan Kutti, Zoya. Try to answer this. I told you whenever there is tumor lysis syndrome, first condition, or second is refractory gout. Refractory gout. In these two conditions, what we allopurinol febuxostat will not work. So in these two conditions, what we gave rasburicase or pegloticase. Clear? In these two conditions, rasburicase, pegloticase, these are preferred. So this we have already discussed. Okay, known case of diabetes, pigmentation of skin over arms, micronodular cirrhosis, biopsy, iron deposits. So this is like an iron overloaded state. So more iron is going into skin. More iron into skin, so you can see bronzing of skin. More iron is going into pancreas. So patient can develop diabetes. More iron is going into liver, so there will be cirrhosis. There will be cirrhosis, right? Okay, so I have added intentionally cases because nowadays in NEET PG paper they are asking you cases only. So in medicine question it will never be a one-liner. So try to just visit this video once again and just don't write, just listen to this video. You will get an idea how to solve the clinical cases in exam. So I have tried to cover almost cases of all the topics. So this is like a condition called hemochromatosis, iron overloaded state. And how we manage this? We manage this by treatment with iron chelating agent. What we have desferrioxamine. The oral form what we have, we call this defibrone. So this is hemochromatosis, or we also call this bronze diabetes. Okay, so this is like a 38-year-old female came to OPD with chief complaint of dry eyes, bilateral parotid gland swelling and difficulty in chewing food. So this is, you can see the clear-cut diagnosis, young female, parotid gland infiltrate, you can see lymphocytic infiltrate in the parotid, dry eyes, right, and difficulty in chewing food. So this dysphagia, the diagnosis is Sjogren syndrome. Sjogren syndrome. Yes, Kishore, phlebotomy is the treatment of choice. This is a condition hemochromatosis. So if I say in hemochromatosis, the treatment of choice is phlebotomy. Behcet syndrome is called silk root disease. Silk root disease means here you will see the patient will have recurrent oral ulcers. There will be genital ulcers. Oral ulcers are more common and genital ulcers are more pathognomonic, and there will be a positive pathology test. Positive pathology test. The HLA they ask in MCQ, HLA is HLA-B51. Dental caries due to poor hygiene, you cannot see like such fat, that will not cause that parotid swelling. Then keratoconjunctivitis sicca is only like you will see only dryness in the eyes, no other parotid manifestation. This is a case of Sjogren syndrome. The antibody that we see is anti-Rho and anti-La. Okay, next is type 2. Which of the following suggest type 2 hepatorenal syndrome? What is your diagnosis? So very important discussion of HRS. This is again I am writing this expected question in exam. This is expected question they ask about HRS. So let me first tell you something. So whenever I write like this, hepatorenal syndrome or pulmonary renal syndrome or renopulmonary syndrome, so remember what is written first, that is the culprit. Getting my point or not? If I say pulmonary renal syndrome means lungs are creating problems to kidney. So here what I can say, hepatorenal means liver is creating problem. So who is the culprit? Liver. So initially HRS means initially patient is having liver disease, right? And this liver disease progressed to form kidney disease. Simple. So if I write hepatopulmonary syndrome, that means liver disease leading to some pulmonary disease. So whatever it is written first, that is the culprit. So we have two type of HRS. We have type 1 HRS and we have type 2 HRS. In type 1 you will see there will be like patient is already having some sort of liver disease. But remember that diagnosis is clinical, there should be no prior kidney disease. Suppose a few weeks before patient kidney was absolutely normal. So HRS, how we make a diagnosis? Prior kidney should be normal. First thing. There should be no use of nephrotoxic drugs. Second thing. So if you see there will be like increase in serum creatinine and decrease in GFR. So you can write this GFR or creatinine clearance. So creatinine is doubled and GFR is halved. So it is like a doubling of serum creatinine and half of GFR within 2 weeks. If you see this, like doubling of serum creatinine and half of GFR in within or less than 2 weeks. Within or less than 2 weeks, that is called HRS type 1. And if you see increase in creatinine and a decline in GFR, but slowly, gradually, and along with this the patient is having refractory ascites. Refractory ascites means ascites that is not showing response even after total salt restriction and maximum dosing of spironolactone and furosemide. That is called HRS type 2. Clear? So how we manage this HRS? So in both the type we have drugs like what we can give. We can use amiodarone, we can use octreotide, and ultimately last option is we use both liver and kidney transplant. So let us see the option. It is type 2 they are asking. So see, progressive impairment in renal function and a significant reduction in creatinine clearance. Creatinine clearance means GFR. This is nothing, this is GFR. So impairment in renal function means creatinine is increased, reduction in GFR within 1 to 2 weeks. So this is the definition of type 1. Am I clear? This is the definition of type 1. Reduction in GFR with an elevation of creatinine level, but it is fairly stable. This is the definition of type 2. GFR is less, creatinine is increased. Progressive impairment in renal function and a significant increase in creatinine clearance. Is it possible? Do you think? Just see the question. Kidneys are damaged, then creatinine clearance will improve? No. Creatinine clearance is improving means GFR is improving. So this is like a wrong statement, total wrong statement. Reduction in GFR with decrease of serum creatinine level. Is it possible? Again, so answer is B. Am I clear? So remember, GFR means creatinine clearance. So this is an easy question that they ask in exam. Okay, coming to next patient present with foul smelling bulky stool, progressive pallor, hyperpigmentation over knuckle is found. Schilling test is abnormal. So now understand this question. Schilling test is abnormal means this is telling you about B12 deficiency. So what is the Schilling test? First what we do is we give B12. If there is a response with the B12, then this is the dietary deficiency. Schilling test is abnormal and shows normalization with a short period of antibiotic. Like I told you, like there is a bacterial overgrowth syndrome. In that case, first we try to do this with B12. If there is improvement with B12, that's dietary deficiency. Then what we do, we try to give B12 and intrinsic factor. Then if you see improvement with B12 and intrinsic factor, this is pernicious anemia. And if you see improvement with B12 and antibiotic, this is because there are some bacteria which are eating the B12. So this is your bacterial overgrowth syndrome. See. Okay, so you can see here following issues for management of 65-year-old patient with respiratory distress. So patient is in respiratory distress. Echo is having ejection fraction of 35%. So patient is having reduced ejection fraction. So image is little blurred here. So just you can see the question. Let's see the option. Whenever you can see respiratory distress, so there is some sort of pulmonary edema developing in the patient. So in that case, we have to give Lasix. So Lasix is given in all the options. Right? Ejection fraction is low. So let's see option one by one. Lasix, nitrate, sacubitril. So when ejection fraction is less, so patient BP should be on the downside also. Right? So let's see the option one by one. Lasix we give. ACE inhibitor digoxin, there is heart failure, but if you give ACE inhibitor, further this will reduce the BP. Then let's see Lasix nitrate. Sacubitril valsartan we give in stable patient to prevent further reduction in ejection fraction. Do we give Lasix, norepinephrine, sacubitril valsartan? This we can give. But remember here what we see, we can see a pulmonary edema developing in the patient. So it is not clearly shown here, but image is blurred due to some mixing of the images. So what we give here is, again sacubitril valsartan we don't recommend in acute condition. We recommend this for chronic, I can say take home medication. So what we give here, we give Lasix, nitrates and morphine to patient. This will reduce the pulmonary edema. Okay, try to answer this. A 20-year-old patient with shortness of breath and chest pain, she is known case of MS. Young female, MS. Young MS, what you should think? Rheumatic fever. It is rheumatic fever or rheumatic heart disease. So remember, in young patients, generally the cause of MS is rheumatic heart disease. Patients having irregular pulse. So because of MS, irregular pulse means this patient is having atrial fibrillation. No thrombus on transesophageal echocardiogram. Remember, like mitral stenosis will have risk of thrombus formation, microthrombi, like left atrial thrombus. So what agent you will give? So understand this, what agent is best agent to prevent future thrombotic events? So we have a score, we call this Chats-VAS score. Chats-VAS score. This is Chats-VAS score. So in this score, what we see, that we can see like patient is having heart failure or not, there's hypertension or not. We look at the age of patient. So generally we give 1 point to each category, and we give 2 points to A, and we give 2 points to S. Remember, 2 points we will give to me. So my name is Aman Setiya, AS. So remember, this is 2 points. Another place what we give 1 point to each. So whenever you see like a patient who is having irregularly pulse, there is atrial fibrillation, we need to give some prophylaxis of anticoagulant. Right, we give prophylaxis of anticoagulant based on this score. So you can see patient age is young, so there is nothing about age criteria. You can see patient is having mitral stenosis, irregular pulse. So right now there is no thrombus, but this is like a risk factor for further thrombi formation. So we have to give anticoagulant. So they are asking you best agent to prevent future event. Dabigatran is a novel oral anticoagulant, so that is not having that promising result as heparin and warfarin. So you can see like heparin is not in the option, so we have heparin in injectable form. So the preferred anticoagulant that we use here is warfarin. So dabigatran, rivaroxaban, apixaban, they are being using now, but again there no proper trial is satisfying the result. Aspirin, clopidogrel, these are antiplatelets, so they will not have any role. So what we use warfarin. 30-year-old man with excessive fatigability towards the end of the day, that improve with rest, gives history of ptosis, difficulty in speech. This speech is called hot potato voice. We call this mushy voice, and difficulty in swallowing. So there is ptosis. What is the diagnosis? Now you can see this SLE, there is no rash, no other feature ruled out. Duchenne muscular dystrophy will be seen in pediatrics population. So it will be seen in less than 10-year-old child. Now we have two differential, myasthenia, LEMS. So myasthenia gravis, remember myasthenia gravis is something This is something like more patient is having more fatigability towards the end of the day. So I can say myasthenia is something that is this will worsen with activity or exertion. On the other end, Lambert-Eaton myasthenia syndrome. Lamb says Lambert-Eaton myasthenia syndrome. This will improve with exertion. So myasthenia patient, they will be more tired towards the evening, where Lambert-Eaton will be more excited in the evening. So diagnosis is clear, myasthenia gravis. Clear? Am I clear? Okay, so let's see. This is the myasthenia gravis. What we see, you can see like this is ptosis, drooping of eyelids. So after giving adrophonium 10 mg, so what we give first 2 mg followed by 4 mg, then we wait for the response, then again we give 4 mg. So do not give this 10 mg start dose, 2 for 4. Then you can notice ptosis improve. This is called tensilon test or adrophonium challenge test. Clear? Tensilon test or adrophonium challenge test. So whenever you are doing this test at the backup, like as a stepney, keep one more drug available with you, because anytime patient can develop cholinergic crisis. Here, yes, LAMS, Madhavan, LAMS is a paraneoplastic syndrome of which cancer? This is for small cell lung cancer. LAMS is paraneoplastic symptom of small cell lung cancer. Clear? Okay, coming to next. Right? Try to answer. A 68-year-old female present with cough with yellowish sputum. Cough, yellowish sputum, auscultation, bronchial breath sound, hemodynamically stable, not confused. On examination, respiratory rate is 20 per minute, BP is 110, urea is 44. What is next step in management? So you can see like you can see bronchial breath sound. So this is a case of pneumonia. It's a case of pneumonia. So in pneumonia, what we have a score called curb 65 score. So what is this curve 65 score? Understand this. Curve 65 score means the patient is having confusion. U is urea. If urea is more than 20, R is respiratory rate, B is BP. BP means patient is having hypotension. So BP decrease, respiratory rate increase. 65 is age of patient. So what we give, we do is we give 1 point to each category. If patient is confused, 1 point. Urea is increased, 1 point. Respiratory rate is more, we give 1 point. BP is decreased, we give 1 point. Age, we give. So understand this, based on this we will calculate the score, and after this what we can say, once you calculate the score, after this you need to decide. So if it is like score is coming in the range of 0 score, nothing, just the treatment will be on OPD basis. If score is coming like 1 and 2, then we should admit the patient in ward. This is like admit in ward. And if score is coming 3 or more than 3, then admit the patient in ICU. Admit in ICU. So let us see the question now and try to calculate the score. So you can see 68-year-old. This is the 1 point. Clear? Cough with yellow sputum, auscultation release, hemodynamic stable, non-confused, not confused. So there is no confusion. Respiratory rate is 20. This is also normal. BP is normal. Urea is slightly increased. Urea is 44. It is more. Urea should be less than 20. It's 44. So 1 point here. So total how much score we have? We have 2 points. So 1 plus 1. So total there is 2 points. And 2 point means what we do? Admit in ward. So admit in, give antibiotics and home. Admit in ICU? No. Admit in ICU? No. Admit in non-ICU setting, that is admit in ward. So answer for this question will be D. Clear? Okay, next try to understand this. You can see like again this is like we call this ribboning. You can see ribbon like. अभी आ रही है आवाज? Anti-UVR and RNP where we see in mixed connective tissue disorder. Am I audible, guys, now? Am I audible now? Okay, just a second, we are fixing the issue. Okay, guys, so anti-U1 RNP. Am I audible now? This is seen in MCTD, mixed connective tissue disorder. Anti-Smith, you all know this anti-Smith is SLE. Anti-Smith we see in SLE. So let us see now, A will be 5. So these two are ruled out. Now see anti-topoisomerase in systemic sclerosis. So B is 3. B is 3. So this is the answer. Is it clear? So this is like sometime they can ask you MCQs based on this antibody. So just quickly say this: anti-Jo1 in dermatomyositis, polymyositis, anti-topoisomerase where we see in systemic sclerosis. There is one more like CREST syndrome where we see anti-centromere antibody. Anti-U1 RNP in MCTD, anti-Smith we see in SLE. Now try to answer this question. A patient comes to you with emergency room with headache that he describes as worst headache of his life. So worst headache of his life. So I will give you a hint and you will tell me the diagnosis. The answer is SH. This is a case of subarachnoid hemorrhage. What is the next step? What is the next step? What is the next best step? Hashimoto's, Dr. Hashimoto's. Try to answer. What is the next best step? What do you think? A, C, T, different answers are coming. Okay, so see this. In this question, this is SH. So the best test for diagnosing, next best test for SH is lumbar puncture. In lumbar puncture, what we see xanthochromia, xanthochromic CSF. Xanthochromic CSF. So answer for this question is lumbar puncture. Okay, so like I can see here, Akash, Richa, Zoya, Hashimoto's. Why you made a mistake? Let's just look at the screen. In the same question, I will make some changes now. If I remove the word best, so what is the next step? Then diagnosis will be CT brain. Clear? So if I remove the word best, then answer will be CT brain. But in the question it is mentioned next best test. Am I clear? So approach will be, suppose any person who is coming to you with SAH, subarachnoid hemorrhage, whenever you suspect. So how you will suspect? So patient can have vomiting, right? Patient will have loss of consciousness, right? There will be hypertension, there will be a shooting of BP, his blood pressure is like 190, 200. So straight away what we do CT scan. Which type of CT scan? Non-contrast CT scan. Non-contrast CT scan. So once we do non-contrast CT scan, in this contrast CT scan you can differentiate is like ischemic stroke or hemorrhagic stroke. So whenever you suspect bleed, so if bleed is present, right, and we want to see the extension of bleed, so to confirm this, what we can go for, initially we will do for a fundus examination. If fundus is normal means no papilledema. If fundus is normal, then we can go for an LP, lumbar puncture. Sometimes small bleed is not visible in CT scan. So remember, this is like a same question. If I ask you what is the next step or what is the next thing you will do in emergency, that is CT brain, but next best step is lumbar puncture. Am I clear? For SH, remember the drug that we use is nimodipine. Generally you will see like in the brain CT bleeding will be near Sylvian fissure, and remember the prognostic scale that we use is Hess and Hunt scale. Hess and Hunt scale that we use for SH. Clear? So see the question carefully because they ask this type of question in exam, and I don't want you to make mistake there. Try to answer now. Bigger question, the bigger the question the better it is. 48-year-old smoker, hypertension, patient is taking enalapril. Enalapril means ACE inhibitors. Hydrochlorothiazide means thiazide. Episode of hemoptysis, and he was having bronchogenic carcinoma with brain metastasis. Sodium is 124. Sodium is normal value is less or more? It is less, right? 135 to 145 is normal value, is 124. So 124. Creatinine is slightly higher. Blood sugar normal. Blood urea 24. Serum osmolality is 285. Urine osmolality 350. 24-hour urinary sodium is more. So I am highlighting the things for you. Now you will tell me the first what it is. So understand this, what it is. It is a case of a smoker who is having lung cancer, right? And now this patient is presenting to you with hyponatremia, right? There is brain metastasis, there can hyponatremia. So understand this, lung cancer can produce something called like this may be small cell lung carcinoma, which is producing a syndrome called SIADH. So again you have to interrelate pathology here. Yes, very good, Madhavan. This is paraneoplastic syndrome, SIADH, which is again seen in small cell lung cancer. And this SIADH will produce euvolemic. This will produce euvolemic hyponatremia, right? Euvolemic hyponatremia. And how you will treat this? How you will treat this? The treatment is what we give. We give Vaptans. So like we have tablet of Vaptans, like we in the market we have Tolvas or Tolvaptan 15 mg tablet what we give. So treatment is Vaptans, Conivaptan, Tolvaptan. Is it clear? So understand this. I want to tell you something here. We have cerebral salt wasting syndrome. So see, this diuretic induced hyponatremia, no. Hydrochlorothiazide is not that strong as loop diuretic. If loop diuretic have been given in MCQ, then we could have considered this option. Pseudo hyponatremia, no, it's significant because it's producing symptom also. Now there are two differential. These two things can occur in many brain disease, even like meningitis, encephalitis, brain trauma, brain herniation. These two can present in many brain disease. Like in the question, brain metastasis is also given. So how we differentiate? Remember, cerebral salt wasting syndrome from SIADH. Cerebral salt wasting syndrome, you give IV fluid. IV fluid means you can give normal saline or you can give hypertonic saline 3% NS. When you give these two things, there will be good response. Good response. In SIADH, there will be no response. So in SIADH, what we have to give? We have to add Vaptans. Is it clear? So how we differentiate SIADH from cerebral salt wasting syndrome? Remember, SIADH will have a good response with Vaptans. Salt wasting syndrome will have good response with normal saline. Am I clear? So this is what you should remember about this, because both these are very common in ICU settings. History of fatigue, blood workup is showing hemoglobin time MCV 60. So it's microcytic anemia. Right? Next investigation to be done. What is the diagnosis? Try to answer. Try to answer, guys. What is the answer for this question? This came in last year NEET PG. Try to answer this question. When I see MCV value less than 60, so MCV less than 60 means it's microcytic anemia. Folate and B12. Folate is associated with homocysteine level. Homocysteine levels are increased in folate deficiency and B12 deficiency, and folate deficiency will cause macrocytic anemia. In macrocytic anemia, MCV will be more. Clear? Now see, whenever we see such type of question, what I will suggest you, whenever you see a case of microcytic anemia, then always do something. Whenever we see MCV value less than 80, right? So in microcytic anemia, what we have? We have Sheetal. Sheetal means sideroblastic anemia, iron deficiency, we have thalassemia, anemia of chronic disease, and we have lead poisoning. I repeat, sideroblastic, iron deficiency, thalassemia, anemia of chronic disease, lead poisoning. So straight away what we do is do something, MCV divided by RBC count. Do this. So MCV is how much? 60. RBC count is how much? 5.2. This is what we call MCV divided by RBC count. It's called Mentzer index. This is called Mentzer index. If this Mentzer index values are coming less than 12, less than 13, or more than 13. So understand this. Mentzer index value. So if you divide this, this will be coming if I say it's 5, it will come around 12. So this will be coming around 11.8 something. So if values are less than 13, so means values are low. Or values are more than 13 means values are increased. So understand this, if Mentzer index value is less than 13 or low, then there is more chance of thalassemia. And if Mentzer index values are more than 13, increased value, I for increase, then there is more chance of iron deficiency anemia. So why it is important, and understand this, lead poisoning, there will be some history of like working in battery industry, paint industry. Anemia of chronic disease, there should be some history of chronic inflammation like rheumatoid arthritis, they can give ulcerative colitis, they can give you Crohn's disease. Then remember in sideroblastic anemia, again there will be some like patients taking isoniazide, that kind of history, or patient is having deficiency of pyridoxine. So main difficulty we have in microcytic is to differentiate between iron deficiency and thalassemia. Now you will tell me, sir, thalassemia is always severe. No, thalassemia can be minor, it can be intermediate, it can be Cooley's anemia, which we call thalassemia major. So main difficulty what a physician, a doctor feel is to differentiate iron deficiency anemia from thalassemia minor. And that how we can, because thalassemia minor patients are also like normal people, like iron deficiency anemia. Both they look normal. So how we differentiate? By doing a Mentzer index. So serum ferritin level is for iron test. Here a value is coming less. So what we check? We do thalassemia. How we make a diagnosis of thalassemia? The best test is high performance liquid chromatography. If this is not in the option, then what we check? We check for hemoglobin electrophoresis. Hemoglobin electrophoresis means we are seeing the level of adult hemoglobin HbA, we are seeing the level of HbA2, and we are seeing the level of fetal hemoglobin. So that is HbA2 level. Clear? So diagnosis will be HbA2 level. Okay, so I know like some of you are wasting huge time in a trial of postponing this NEET PG exam. So now as all of you are knowing, so don't waste your time in satisfying your brain or your heart. Exam is on 5th March, right? So there is no I don't think there's a chance of postponement of this exam now. So you have to study the way you are studying. So don't distract yourself. There are many people. So remember this, मंजिल मिलेगी भटक कर ही सही, गुमराह तो हैं जो घर से निकले ही नहीं. So with this you can see like sometimes they ask you an image based question, so I can show you some of the images so you can get an idea. Just this will be the last thing for today. You can see what this sign I am eliciting here. You can see what we can see here. Which sign is this? This is what we call, yes, see once again, this is Chopstick sign, right? And here you can see once again what you can see in this image. You can see a carpopedal spasm. You can notice, just see the fingers, focus on the fingers of the patient. You can see carpopedal spasm. This is Trossi sign. Just see the spasm here, right? So these two signs are signs of tetanic contraction that we see in patient of hypocalcemia. So lastly what I can say is, no matter how you start, it's time to study for 10 hours a day. That's it, nothing less, nothing more, right? So study 10 hours a day and give your best shot. So remember, there are people like last few days are always crucial. Then those person who study in the last 10 days, they will always get a rank under 30,000. So trust me, just keep studying, 10 hours a day, not less than this, not more than this. More than this you will be exhausted, less than this you will waste many potential MCQs in exam. So try to study hard, focus more on topics. So here I'll tell you the list of the topics which are important as per my opinion that you should consider. So just I am writing the list of topics which they ask in exam, so just focus on this topic. So first I can say this, they can ask you a question on headaches. So especially the last time they have asked a question on headache medicamentosa. So focus on this topic, headache. Second is myasthenia gravis. Myasthenia gravis. Third disease in terms of neurology, remember the stroke treatment part. Stroke treatment part they can ask you in exam. Fourth important topic in electrolyte imbalance, everything is important, especially hyperkalemia management. So I am going into more selective things. Electrolyte imbalance treatment is important. Fifth is they are asking some basic question on ABG, so go with the ABG. Next, if I talk about MI, they are asking nowadays question on stent part, stent CABG. Malabsorption syndrome like celiac sprue, they are always hot topic in exam. Rheumatoid arthritis, SLE, these are two topics that you have to study the last moment. Then this temporal and Takayasu arthritis, because these are like patho medicine overlap topics, so they can ask you a patho question, a medicine question. This vasculitis, you have to study at least these two vasculitis. Next I am writing here Wilson disease. In endocrine, remember a topic called Men's syndrome. If you see the last 3-year paper, they are always asking question on DK. So DK is very important topic. Then focus on sometime I have seen pharmacology question like PCM toxicity, how to manage paracetamol toxicity. That is a question that they ask in exam. Okay, what else I remember? In respiratory, remember they ask MCQ on pneumonia. So read everything of pneumonia. Lung cancer, it's like a patho medicine overlap question. Again, you have to study lung cancer in detail. Okay, then I have seen like they're asking question on sarcoidosis. Always they ask question on sarcoidosis because again it's a topic of both rheumatology as well as respiratory section. That is important. Hepatitis B, which we have discussed the marker part, that you have to study in detail. Either they will ask you a question on HRS, hepatorenal syndrome, or they'll ask you a question on hepatic encephalopathy. So these are the list of topic. I know I can give you more. So let me just write it, the 19 and 20. So 19 will be like just focus on. This time they can ask you a question on anemia, which type of anemia, preferably I am suspecting a question on B12 deficiency or iron deficiency. And if I talk about like we have discussed kidney section, there will be definitely a question on glomerulonephritis and CKD. So these are the two topics that you need to focus. So I am giving you 20 topics. I can give you more, but these 20 topics are must before your exam. So this should be your target. These 20 topics are essential, and from these 20 topics, trust me, you will get around 7 to 8 MCQs in exam. So very important topic list I am giving you. Give your best shot and see you with some more knowledge. So next time we will discuss for your super specialty exam, not for your PG exam. See you there. Bye bye. Take care. All the best. You remember, you can, you will. Bye.